circumstances are not able to join us. But friends, when it comes to improving postgraduate medical education, it's not only over 2 days. The mission and the zeal has to continue over the year. And Professor Mishra will be here, but we will schedule an interactive session with Dr. Abhijat subsequently also virtually, so that we are able to take your voice across to them. So with those words, and also Dr. Sushri is here because she's been running around trying to arrange everything. Thanking you, Rahul, and all concerned, of course, Dipanjali also, in working hard towards the success of this ANBAI Annual Conclave. Welcoming you all, and looking forward to your wholehearted participation in the deliberations of the conclave. Thank you very much.
Thank you, sir, for your valuable message to the audience. Now I request Dr. Arun, CEO of Tata Medical Center. He's a surgical oncologist. I request him to give his valuable address to the gathering.
Thank you, Dr. Lingayya, Vice President of ANBAI, to Dr. Chabra, the President, and the two flag bearers of this installment of ANBAI at Kolkata, Sushri and Rahul. Thank you for bringing an extremely talented group of people to the premises of Tata Medical Center. And what an opportune time, like Dr. Lingayya said, the Durga Puja is just around the corner, and we see that as the monsoons have ended, though it has not ended in most parts of North India, but at least West Bengal, I think we are seeing a change in season, a slight nip in the air in the morning and evening. That is when we say, Puja Asche. So, world Calcutta will slip into slow gear very soon. So just like the hall here will soon fill up, but that's how things are in Kolkata when Puja approaches. So thank you once again, ANBAI, for coming to Kolkata. It's my pleasure, and I say it's a privilege to host you all. You can spend 2 days and savor our hospitality. As a person who has always worked in academic institutions, I can sense the challenge that ANBAI has. Higher education in medicine was restricted to the halls of some of the greatest national institutes, or maybe state-level institutes run by the government. And that was how it was for times immemorial. At a time when I did my post-graduation, I did my DNB. That was for no other purpose other than to sort of stretch the list of degrees that I have to my name. I thought maybe that would fetch some more private practice for me. But then today, it has become an essential part of medical education. Our government-run organizations, or alone, because they also run DNB courses, cannot handle the need to develop specialists and subspecialists in this area. And why not? I think most of these institutes have facilities, they have equipment much better than many of our government-run institutions. And why not our students get the benefit of seeing them, handling it, operating them, coming at par, developing protocols equal to any other country in the world. And that is where the National Board of Examinations has a big role to come in not only running the way we run our postgraduate courses, but how to evolve into the future. You must also realize that today's children do not have the kind of attention spans that we had. We were asked to write essays. Things are changing today. That cram and spit modality is changing today. Things have to be short and sweet and crisp for easy digestibility and easy application. So these are some of the things I'm sure ANBAI will work towards that. But it's really amazing, the journey that ANBAI has taken. So there will be, when we get together, all organizations running or institutions running DNB come together, there will be problems, there will be issues, and there will be a lot of vision with the kind of people who have come together for this meeting, and we lay the roadmap for the future for postgraduate education in India, so that at the end of a master in surgery, at the end of a DNB in surgery, no more would we be forced to do an FRCS, which is called like a forced retraction and a continuous suction. You will be operating at the end of it. So that should be the goal that we must be instilling, empowering students, not just offering degrees on podiums with all the hullabaloo and the brouhaha. It's to empower them, hold their hands to develop that. And I'm sure all institutions in India, whether they are government, whether they are private, need to have a change in the way we look at education. And we are the leaders. You must realize that you are the leaders who are sitting here today. And you will be the force who will make this change. So I'm very, very gratified to be here. I'm very excited to be here, and I'll play host to you for the next 2 days. And whenever I get time from my office, I'll be sitting here listening to you. So thank you so much once again, ladies and gentlemen, for being here with us on Tata on this morning in Tata Medical Center. And I wish you a lot of discussion, deliberation, and some very heated debates in the times to come. Thank you so much. I really appreciate it.
Thank you, sir, for wonderful address, telling about the ANBAI and then postgraduate medical education. Now, thesis and research are the most important things. With that, the students become, they'll improve their groom in their career to be the best professionals. So, thinking that
Recording in
Dr. Chhabra
progress.
and Dr. Rahul, they requested Dr. Ganeshan. Ganeshan is president of Tamil Nadu chapter and is very good academician. So he came forward to conduct thesis competition program to motivate the students to write these good best thesis and do research so that they will improve their career. Dr. Ganeshan, president of ANBAI Tamil Nadu chapter, he has been working vigorously since 7 months, sir, 7 months to conduct this program. Now I request Dr. Ganeshan to come and conduct the thesis competition program. Thank you, sir.
Yes, yes, I know. That's nothing. This way. I'll have to start by saying Vanakkam, Namaste, and Namaskar. Sorry, at the outset, my great reverence to the dignitaries, learned teachers, office bearers of ANBAI, colleagues and students who are slightly sparse now, but hopefully they'll just come in. It gives me immense pleasure to be here in Calcutta today as part of launching this ANBAI academic initiative, which is the ANBAI National Competition for the Best DNB Thesis, which has been a journey for nearly over a year, and it would not have been possible without the unrelenting support and encouragement from the ANBAI office bearers, starting with our President, Dr. Arvind Chabra, our Vice President Lingayasa, our Secretary Rahul, and Treasurer Rishi. So I'm very grateful to all your support and encouragement. The real deal is going to be the 9 speakers, the top 3 finalists in 3 specialties who would come and do their presentation. But before they come, I thought it would be helpful to share some thoughts about the context of this competition, the purpose, and the process, how it came to be. ANBAI's key objectives form the primary context. As many of you would know, ANBAI was born with the aim to unite the National Board accredited institutions, to make them stronger in solving problems together, and working in partnership with the National Board in promoting its goal to deliver excellence. And another important objective is to be a forum to encourage innovative ideas in postgraduate medical education to enhance the standards of our students. The other context, whenever we think of, is not just about us, it's about what is around us as well, the opportunities and challenges. In terms of opportunities, again, many of you would have recognized that National Board has got a unique character in being able to have national level impact in full spectrum of postgraduate medical training, which is starting not just with setting standards for the institutions and the course, but also conducting the assessments in terms of their exams and dissertations of all the PGs. This is different from NMC, where although it sets standards, the evaluation or the assessment part is devolved to the universities and the hospitals. So that way, NBE has got a very unique position, and we need to harness the benefits of that. And ANBAI very closely shadowing the NBMS in terms of helping all the National Board accredited institutions in delivering those quality standards set by National Board. So if a change can come at national level, that can only be through National Board, and that can only be with the help of ANBAI. In terms of challenges, there are historic challenges and there are new age challenges, as I would like to call it. The new age challenge, I'm sure many of you recognize, many medical teachers would recognize, that we now are to meet the expectations of the Gen Z learners in higher education. We need to almost get into their head to think like them, to understand how to engage them. The traditional methods of 30 years ago, what we did, will not work, and there is no point in keep talking about it. So we need to come up with, and it is not just about technology, it's about curiosity, it's about asking questions, and accepting that people can ask questions. And that requires a kind of cultural change. I think that I consider as the biggest challenge for those of us who train without asking, just implicit obedience, as my father used to say, to a generation where they would be asking questions. The other challenges which have been historic is our recognition to move towards deeper learning strategies to improve understanding, rather than, as Professor Arun was saying, from the rote learning kind of thing, just simply learn and then eject it. And the third important challenge would be to promote experiential learning. Anything which is learned that way is what is going to stick. And that is what every medical practitioner would be, that is what is going to help every medical practitioner to become self-directed lifelong learners. So they can't be just spoon-fed their lifetime. They need to take initiative to become self-directed lifelong learners. So that is another challenge. Then in specific terms of teaching and assessing clinical skills is a big challenge, which has always been. The same way professionalism and professional attitudes, which are becoming more and more important. So it is not only just teaching them, finding ways to teach them, but also assess them. Having set the context, now about a year ago we were asking, if we are coming up with new initiatives through the ANBAI platform, what should we aim to achieve? We should add value. There are some statements made. That is, one of them was we should add value to the current academic programs for National Board trainees across multiple specialties, which are very well conducted in many good hospitals and also delivered centrally through National Board from the COVID times. And secondly, we need to be able to stimulate our National Board PGs to become better clinicians, to commit them to become self-directed lifelong learners. And thirdly, ANBAI can become a platform for promoting something innovative, as its key objective states, to have an impact on the academic culture across the country by promoting evidence-based practice and research. So with all that was born the ANBAI National Competition for the best DNB thesis. We don't want it to be just a competition, but just the start of a journey which builds on the strength of, which builds on the existing academic strengths of our National Board trainees who spent a lot of time and put in a lot of effort doing their DNB thesis. But we all know that only a very small proportion of these thesis work, even the PGs themselves look at it again or manage to get it published. So we want to push the PGs to move to the next level, to identify their potentials, and we want to nurture them to pursue a career with a significant academic component, although we can't deny the importance of money. And we should encourage them to pursue evidence-based practice and also demonstrate how it is possible. And all of this will help us to identify future academic leaders, and we would encourage them to engage in research relevant for Indian patients. And that is the critical bit, rather than quoting research done elsewhere in the world. So with all those lofty ideals, we started with, we finalized this competition flyer around April time. As you could see, the ANBAI has invited all the National Board Accredited institutions to encourage their final year trainees to submit their abstracts for the national competition. The eligibility criteria were defined, deadlines and timelines were drawn. And we thought, having started in April, by the end of the year, we may be able to conduct the competition for 7 of them, 7 specialties. 3 of those would be presenting their sort of thesis abstracts today. And we also had clear note for the contestants. We set the standards in terms of, for the structured abstract and template, and the instructions were also there. And we, in addition, wanted to make sure that these theses are approved by National Board, and also we provided them a facility to become ANBAI alumni member by filling a Google form. So these are all the process part of it. And this is the template of the abstract, the 300-word abstract, how it should be constructed, and the instructions are embedded in the body of the template. And those abstracts, again, we developed another tool to evaluate and score these abstracts. We wanted it to be robust without bias by combining the explicit expectations set in the instructions on the template abstract with the specialty expertise, domain expertise of the faculty judges. In that, we wanted to give a degree of structure and broader rails within which they need to operate, but at the same time have the flexibility to address the nuances of variations in entries from across the country. So the abstracts were anonymized along these lines with deleting the names of the the PG and the institution. And the judges were given this score sheet to evaluate the abstracts under 5 categories: title, background and objective, materials, methods and results, which is the observation of the thesis, conclusion of the thesis, which is the inference, and then the impact and the implications for other practitioners, for the wider profession. So on this basis, all the theses were evaluated. And at this juncture, I'm very grateful to the senior faculties from across the country who spared the time and effort in evaluating this thesis. For DNB General Medicine, it was Dr. Himanshu Bateja from New Delhi, Professor Balaraju from Hyderabad, who is here with us today, and Dr. Rangaprasad from Chennai. For DNB Obstetrics and Gynecology thesis, it is Dr. R.T. Singh from Kanpur, Dr. Niranjana from Chennai, and Dr. Bhagyalakshmi from Secunderabad. And the judges for DNB Orthopedics thesis were Professor Dr. Sivakumar from Madurai, Dr. Sunil Kumar from Delhi, and Dr. Krishna Subramaniam, who is also with us today, from Hyderabad. I'm very grateful to all of you, sir, for evaluating these theses. So having done this year's competition, we are looking ahead how we can improve on the process for the next few years. And we want to balance our aspirations with the reality. We would like to move towards a rolling program of running a competition, 1 specialty a month, so that the annual awards can be for 12 specialties. And the abstracts would have the same template, as they seem to have worked well, as would the structured scoring system as well. But we'd like to conduct the competition at 2 levels. The first level would be the online abstracts, which would be evaluated by non-native zones. What I mean by that is we have divided India into 4 zones, and if somebody is presenting from the south zone, then it will be judged by judges from the other 3 zones. So that way we completely, or as much as possible, eliminate the element of bias. So that is what would be done, and that would distill out the top 6 abstracts, thesis abstracts in each specialty. And these top 6 oral presentations would, all these top 6 PGs will do an oral presentation as they're doing today. But it will happen every month, and it will be hopefully be live streamed nationally for the specialty PGs from across the country to watch. And the top 3 selected in that second level competition by the national panel will be given awards in the conclave. And we are also committing to support all the participants to work towards publishing their thesis. And all this can happen only if there is greater level of engagement of ANBAI members. So in terms of if we're thinking what are the benefits for ANBAI through this competition conducted this way, more hospitals will become members, and we can also make that this competition is open only for ANBAI members, whereas this year we have been a bit generous by saying that even non-ANBAI members can participate. And that way ANBAI would achieve one of its key objectives of serving as a platform to promote innovation in medical education, which is research publications. And benefit for the institutions would be that it would enhance the profile of their organizations when trainees participate and get award, and also when their faculty contribute to becoming the zonal or the national level judging panels, that also will add kudos to them. Finally, what are the benefits to the national board trainees? All the time and effort they have spent in doing their thesis is recognized, and ANBAI will help and support every submission towards publication, and we hope that at least 50% success rate we'll have. And if they get a national award, obviously it will enhance the CV, especially for selection of faculty posts. So with that, I would like to reiterate that we do not consider this as just one more competition, but it's the start of the journey which identifies the potential of those DNB PG trainees who have got a greater commitment to academia, and then nurture them and to pursue a career in academic component and pursue evidence-based practice, thus having an impact on the clinical practice, but in addition to identify future academic leaders to encourage them to engage in research relevant for Indian patients. For this, we need you. We need more NB institutions to become ANBAI members. We need more DNB thesis abstracts, and we need more DNB faculty judges in the years to come. So with that, I would stop, if there are any questions. If there are no questions, then probably we can move on to the next session of bringing in the 9 speakers one by one. Are there any questions? No questions, okay, that's fine. So.
Very impressive. I think it's the academic thing what you have done, sir. Just wanted a question is about the AI. Like in your consideration, did you consider AI or where? Just wanted to know if they were using AI. Did they have to? Is it allowed, or is it they have to disclose this when they were writing abstracts and things like that?
Okay. Firstly, the abstract was supposed to be based on their thesis. So if they found a mechanism of feeding their entire thesis into an AI this thing and then fill an extract, probably yes. But interestingly, the practical observation is in the first wave, about 7 or 8 of them, it was nowhere near the abstract instructions. So they haven't had time to read even the instructions for the abstracts. So I don't think they would have bothered to just do AI, at least this time. And but on a serious note, we have not considered AI-generated abstracts as part of it. And we have not asked for any disclosures as of this year, okay. But probably we need to protect ourselves next year.
Because now, even in our students, we tell them if they use it, you have to disclose it and things and the reference has to be checked. That's how we say it, because even if we don't say, otherwise they'll do it wrong way. So I just wanted to.
Yeah, sure. I mean, if it was an independent writing, definitely that would have been a question, because this is their thesis abstract, and we got proof that it is approved by National Board. Hope is that probably it was just a summary of that.
I think what Carol has raised is an important issue. There's a lot of debate across the globe on the how we monitor the use of AI, whether we should encourage it or discourage it. But it's true, you can just upload your thesis and then ask them to make an abstract for yourself and it comes out. So that needs to be discussed thoroughly, I think, in the governing council on whether we allow it. Again, AI, how you use the AI is also important, right? The results will come out on how you use it. So, very point well taken. We'll discuss it in the governing council,
Yeah.
and then we will take a call on it.
So one of the guardrails we have created is in the the abstract, structured abstract, there are very specific pointers which have been laid down. So they will have to program the AI to give an abstract along those lines. Oh, okay. Maybe I'm not that well versed with AI.
I'll
should
just
say.
make one comment.
Sure, sir.
Just like you do plagiarism check, now there are softwares available. If you select that abstract, it will tell you AI generated. So you always know that yes, this has been generated by AI. So when the candidate is giving an undertaking that he hasn't used AI to make this abstract, you'll all know.
Okay, we'll probably incorporate it. We haven't sort of thought about it this year. I believed in the goodness of people, but probably, yeah, Gen Z, we need to understand how they work. Okay, fine. Now, sorry, the IT person, yeah. You made a phone call. Bijesh. No, 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 this. No, no, you'll have to go into the room, waiting room. No, no, you don't need them. Zoom का जो waiting room है वहाँ से. Oh, अच्छा, अच्छा. You have to allow Dr. Bijesh. But I'll have to give an instruction. Sorry. Can my slide be shared? Yes. Can this be shared? Yes, yes. Okay, we are moving to the next part of the session where the 9 presenters would come. I would like to start this session by again thanking the judges for the first section. So we're going to run half an hour of each session. First half an hour is DNB General Medicine. Second half an hour is DNB Obstetrics and Gynecology Abstracts. And third half an hour is DNB Orthopedics. The General Medicine section, the judges, again, I'm very grateful to each one of them. Dr. Himanshu Bateja from Sri Balaji Action Medical Institute, New Delhi, Professor Balaraju from Yashoda Super Specialty Hospitals, Hyderabad, and Dr. G. Rangaprasad from Vijay Group of Hospitals, Chennai. Now, I would invite the first speaker, Dr. Bijesh. Dr. Bijesh is from Shifa Hospital, Bangalore, and he did his thesis under the guidance of Dr. Altaf Ahmed. So over to you, Dr. Bijesh. You need to share your slide first.
Please.
And then once you share, we will start the timer.
Just one thing. Yes. Yeah, yeah.
Yes, Dr. Bijesh, you can start. Start the timer. Excuse me. His audio is not. Dr. Bijish, you'll have to unmute yourself. Go back to 6 minutes. 6 minutes. Don't start it until he starts. Dr. Bijish, we can't hear you. You have to unmute yourself
Hello,
and share
can you
your
hear?
screen. We can't hear
Can you
you.
hear? Hello, can you hear, sir?
Yeah. Share your slides, please. Sorry, the IT person, please don't leave.
Can you hear?
Yeah. Only when you start. Yeah, you can start talking. You start your presentation, doctor.
Good morning, respected judges, faculties, and colleagues. I am Dr. Bijish PR, internal medicine from Shifa Hospital, Bangalore. Today, I'll be presenting my thesis titled A Cross-Section Study on Thrombolysis in ST Elevation Myocardial Infarction and its assessment with respect to ST segment resolution and time delay. Background: acute coronary syndrome, ST elevation myocardial infarction is a leading cause of death worldwide. The treatment of choice is primary percutaneous coronary intervention if the door to balloon time is less than 120 minutes, or thrombolysis. What's the relevance of this thesis in the current era of primary PCI? India as a developing country, most patients receive thrombolysis. There are certain limiting factors for primary PCI like cost factor. Primary PCI cost starts from 1 lakh up to 3 lakh or more. And streptokinase even costs merely.
Sir, please, I just interrupted you. I want to say you something that you have the please share your slide and change the slide, please.
You're stuck in the
Faster.
first slide itself.
I have changed the slides.
We can't see it here. Just, you'll have to log out and probably share your slides again.
Please. Yes. Share the screen, entire screen. Share the entire screen.
Okay.
Yes. And now,
Presentation.
yes, presentation.
Start from beginning.
Yes, please. Yeah.
So, good morning, respected judges, faculties, and my dear colleagues. I am Dr. Bijish Pia, DNB Internal Medicine resident from Shifa Hospital, Bangalore. Today, I'll be presenting the thesis titled A Cross-Section Study on Thrombolysis in ST Elevation Myocardial Infarction and its assessment with respect to ST segment resolution and time delay. So, background for my study: acute coronary syndrome, ST elevation myocardial infarction, is a leading cause of death worldwide. Treatment of choice, as we know, is a primary percutaneous coronary intervention with the door to balloon time less than 120 minutes, or thrombolysis. So, what's the relevance of this topic for my thesis in the current era of primary PCI? As we all know, India as a developing country, most patients receive thrombolysis. There are certain limiting factors for primary PCI. Cost factor that primary PCI costs from 1 lakh to 3 lakh or above. And cath lab facilities are not widely available, lack of cardiologists, and door to balloon time cannot be maintained. Adequate treatment cannot be given. Additionally, the certain socioeconomic and lack of awareness leads to delay in treatment. Coming to aims and objectives,
They're showing different time.
my study aims at analyzing the effect of time delay on the success of thrombolysis. Additionally, the role of anatomical location, that's anterior wall MI, inferior wall MI, or posterior wall MI on the success of thrombolysis. Influence of risk factors like diabetes mellitus, hypertension, dyslipidemia, smoking on the outcome of thrombolysis also studied. So materials and methods. So study duration was from 12 months from June 2022 to May 2023. We studied in 100 patients presenting with a STEMI at Shifa Hospital, Bangalore. Patient aged 25 to 85 years presenting within 48 hours of chest pain was included in the study, and patient with NSTEMI and LVB was excluded. Methodology,
Sir, please
yes,
change your slide, sir.
sir, I'm changing, sir, here.
Go into full presentation mode.
Sir, I'm changing slides. Can you see the slides?
No.
Okay, fine. Finish. Carry on, Doctor. Sorry, carry on from where you left.
Yes. The time delay in initiation of thrombolysis with streptokinase was given, administered 1.5 million units over 30 to 60 minutes. ECG taken before and after 90 minutes after thrombolysis was taken. Then successful thrombolysis was taken as ST segment resolution more than 50% 90 minutes after thrombolysis. Coming to results, the mean delay in initiation of thrombolysis was 12.1 hours with an overall success rate of 51%. If we dissect out the time delay and success of thrombolysis, we can see less than 3 hours, 93.1% success rate, 3 to 6 hours, 92.3, 6 to 12 hours, 55%, more than 12 hours, 5%. So we can see from 0 to 6 hours, above 90% success rate. Here in the graph shows from yellow with success rate less than 3 hours and up to more than 12 hours with the green with a high failure rate. Coming to next slide. Failure rate in diabetes was 68% and hypertension 62%, which was statistically significant. Anatomical location, as we saw, anterior wall MI, inferior wall MI, posterior wall MI in this chart, failed to achieve significant level. Other comorbidities like dyslipidemia, smoking were also did influence the outcome of thrombolysis. Next slide. So this study aligns with the landmark Gusto trial with 90 minutes patency rate of occluded artery was 54% with the streptokinase. Meta-analysis Keeley et al. Primary PCA success rate was 90 to 94%. EC trial showed that shorter the time delay in thrombolysis, higher the chance of survival and success rate. Shazia Hamid and colleagues in that study, diabetes hypertension was smoking was associated with increased failure in thrombolysis. So to conclude, thrombolysis, especially in the first 6 hours, increase the success rate of thrombolysis. However, majority of our patients miss this golden hour. And diabetes mellitus, hypertension can be a contributing factor for a failure of thrombolysis. So final key takeaways, reinforcing time is muscle. Myocardium, once lost, is lost forever. So it leads to increased mortality and lifelong they have to suffer cardiac failure and its consequences. Golden hour of thrombolysis have comparable results with primary PCA as in our study, above 90%. So public awareness and timely medical attention are crucial in that. As treating physician, we can play an active role in raising the public awareness and bridging this gap. I sincerely thanks the ANBAI committee and everyone for this opportunity. Thank you. And I can take questions.
Yeah. Just look for any questions in the chat box. Okay, there is a question. Can somebody give a mic, please? No, it's just to keep the audience engagement, that's all. It's not going to matter in terms of judging. Already, whatever is judged is.
Thank you, Brijesh. Just one question. You said among diabetes and others, there was a significant difference statistically. Can you hear?
I can't hear. A little low.
Okay.
Audio is a little low.
You have said that there's a statistical difference between
Yes.
diabetic and non-diabetic in failure and success rate. Correct, no?
Yes.
Uh,
Diabetes and hypertension
and
influence the outcome of thrombolysis.
yes, so outcome as success and failure, isn't it? Outcome is
Ah,
success.
yes.
So, what was the finding? What was the finding? That you can't do it, it's not a good modality in them? Is that what the finding? What was the significantly
No,
difference?
actually, our studies showed that diabetes and hypertension have increased chance of failure.
Ah,
So,
that's what.
such patients we can still administer, but this portion we have to the chance of failure. If the thrombolysis is failed, we have to immediately take them for emergency PCI or other
Okay,
things at the earliest within 24 hours. So we can anticipate in such patient with the long-standing diabetes hypertension.
okay. Thank you. That was my question. Thank you.
Thank you.
Thank you, Dr. Bajish. You can leave and go back to waiting hall. We'll call the next candidate, actually. Can you please
Okay,
do
thank
that?
you.
ये जो इसको वेटिंग हॉल में लगाना कनेक्शन नहीं Please unmute yourself. Yes, sir. Next is Dr. Mahidur Rahman from Apollo Multi-Speciality Hospital, Calcutta, who has done his thesis under Dr. Jayanta Sharma. Please share your screen, doctor.
Okay, sir.
Share your screen and put in full presentation mode. Logged up. Can you just log in? Can you allow him in? Dr. Mahidur Rahman.
Sir, am I visible and audible?
Yeah, we can see your screen and you're audible. You'll have to go into full PowerPoint presentation mode.
Okay, sir. So it's okay.
Yeah, this is fine.
I am Dr. Mohidur Rahman, third year General Medicine DNB trainee from Apollo Multi Speciality Hospitals, Kolkata. Today I will be presenting my study, a cross-sectional study to assess the prevalence of sarcopenia in end-stage kidney disease patients who are on maintenance hemodialysis. So to begin with, sarcopenia, according to European Working Group on Sarcopenia in older people, is the presence of low skeletal muscle mass and either low muscle strength, or that is measured by hand grip strength, or low muscle performance, that is measured by walking speed. And when all the three conditions are met, severe sarcopenia is diagnosed. So sarcopenia is relevant as it increases risk of falls, fractures, physical disability, and diminishes the quality of life. And it also causes unfavorable post-operative outcomes, resulting in increasing healthcare service burden and costs. Muscle loss is a frequent finding in chronic kidney disease patients, especially it gets more aggravated in end-stage kidney disease who are undergoing maintenance hemodialysis. So after reviewing our literature, we found overall prevalence of sarcopenia worldwide is 4% to 63%, It was more prevalent in Europe and South American countries. Our previous researchers used different diagnostic criteria given by European Working Group of sarcopenia in older people criteria, or International Working Groups criteria, or Asian Working Groups criteria in different populations. Their key observations were low muscle mass and low muscle strength were common findings in all patients of sarcopenia. Sarcopenia was found to be an independent predictor of mortality in several studies, and low muscle strength was associated with mortality in sarcopenia more than low muscle mass alone due to falls and all. So we found a few gaps in our existing knowledge. There was no Indian study previously, limited representation of diverse populations, like more of Asian populations were not there. Impact of comorbidities like diabetes, hypertension were not properly studied, and studies addressing the effect of interventions were very few. So our aim was to find out the prevalence of sarcopenia in patients undergoing maintenance hemodialysis for chronic kidney disease. Along with this, we wanted to find out the percentage of probable sarcopenia who were with low muscle strength alone, uh, and to find out the correlation between the presence of sarcopenia with factors like age, sex, body mass index, comorbidities, duration of dialysis, nutritional disturbances, and dialysis related factors like uremia, hyperphosphatemia, low calcium level, also inflammatory status. We also took diet into our concern. So we did an observational cross-sectional study in the dialysis unit of Apollo Multispeciality Hospitals, Kolkata, with 112 participants who were undergoing maintenance hemodialysis, who were down in the 6 months of the dialysis. We excluded patients with arthritis of both hands, neuromuscular diseases, malignancy, symptomatic heart failure, severe nephrotic syndrome, and long-term steroid recipients. We used the criteria given by European Working Group on Sarcopenia in older people for evaluation of sarcopenia, that is FACT strategy, find cases, then assess, confirm, and severity. We found cases by SARC-F questionnaire, which is 4 by 10 is the ruling disease ruling in condition. Then muscle strength was checked by Cambridge handheld dynamometer, and we confirmed sarcopenia by skeletal muscle mass index calculation, which was given. We did it anthropometrically because of resource constraints. We The formula was given by Ryoto Kawakami in 2021 from Japan. So our observed prevalence of sarcopenia was 68.8%. It was more frequent in males than females. And 11% participants had probable sarcopenia who were having low muscle strength. Our observation was skeletal muscle index and hand grip strength were significantly low in participants with sarcopenia, whereas individuals with probable sarcopenia had an higher average muscle mass than the non-sarcopenia group. It suggested that hand grip strength or muscle quality is independent of muscle quantity while predicting sarcopenia. Independent factors predicting sarcopenia were increasing age, low body mass index, high SARC-F score, more duration of dialysis, low daily protein intake, infrequent physical activity and exercise, along with high urea creatinine level, low serum albumin, high phosphate, low calcium and vitamin D3, and raised CRP. The modifiable risk factors were related to mostly nutrition and physical activity. So to conclude, we got significantly high prevalence of sarcopenia, where more than 2/3 of the patients were sarcopenic, mostly due to inadequate nutrition, lack of physical activity, pre-existing comorbidities, and inadequate dialysis, inadequate clearance of urea and creatinine. The scope for intervention were prescription of adequate nutritional therapy in the form of diet, total calories and protein matched with body weight, supplementation of calcium and vitamin D3, encouragement of regular aerobic exercises, adequate dialysis, and urea solute clearance. Thank you.
Thank you, Dr. Mohidu. I'm open for any questions, and yeah, Dr. Carol has a question. Can somebody pass the mic on to her, please? Yeah, sure. Dr. Mohidu, can you hear from the audience?
No, sir, I can't hear till now.
Yes.
Yeah.
Mohidu, can you hear? Can you hear me, doctor?
That's a prelude for your question, Carol, because you keep asking questions. That's what.
Dr. Mohidul, can you hear me? Can you
Yes,
hear
sir.
me?
Yes, sir. Yes, ma'am, I can hear.
Okay, so a very nice presentation. Sarcopenia is something, as you rightly said, is not studied, but just have questions. One is, you have taken hand grip, right? Is it a dominant hand grip that you have done? Because both hand grip will be differing. Did you do
Yes,
that? Is it the dominant hand grip?
yeah, ma'am. I have used the hand grip of dominant hand.
Yeah, so that is one thing. And you have done a cross-sectional study. Now, in the cross-sectional study, in the results, you said uh, some things are predictors. You cannot comment on a prediction because it could have together existed. I just wanted to say that part of it. Okay.
Actually, ma'am, my objectives were two. Primary objective was to find out the prevalence, that is 68.8%. And ma'am, my secondary objectives were to find any correlation.
Yes, you can
So
say
I did that
associated.
in my secondary objective.
Yes, you can say associated. Prediction can only be, cannot be as an outcome of a cross-sectional study. Okay, that is. And you said, yeah, and you said females have, males have more sarcopenia, but there is,
Yes, ma'am.
I think there's no, you have not done a statistical significance there, so you can't just say one is better just by the numbers. These are comments I just want to tell you. Okay, thank you.
Okay. Yes, ma'am. Thank you.
Thank you, Dr. Carol.
I have one more question here.
Oh, okay.
The question is, you have checked the serum creatinine and association with this sarcopenia? What is your finding? Serum creatinine and this sarcopenia.
Yes, sir.
What is
Sir,
your
it
finding?
was positively associated with serum creatinine. As the serum creatinines were high, in between two sessions of dialysis, some more the prevalence of sarcopenia were there.
So, but then I mean, final studies have shown that there is a reverse epidemiology. People with a larger muscle mass, higher creatinine, they do better. They are less sarcopenic because they have more muscle mass and therefore they produce more creatinine. I mean, that should be a reverse one. So you should go back. The other thing is that you should measure the, I mean, adequacy of dialysis. So you have to take all patients who are on 3 per week, and then all patients have got a minimum T2/V, I mean, more than 1.25. Otherwise, you cannot standardize between a, I mean, poor quality dialysis and versus a patient who is receiving high quality dialysis. And you cannot compare the sarcopenia between a, I mean, poor dialyzed patient and versus a adequately dialyzed patient.
Yes, sir.
Thank you. Yeah, sorry, go ahead, Dr. Rama.
Yes, sir. Yes, sir.
Okay, thank you very much for those comments, Dr. Rahman. Probably you could just look at your data in light of the comments made and then see whether they were all adequately dialyzed. And with that, probably we'll let you go. Thank you. You can go back to the waiting room, and all of you will have to come back at the end of the session when we announce the results.
Okay, sir.
Next speaker is Dr. Agarwal from Sri Balaji Action Medical Institute. He did his dissertation under the guidance of Dr. Sera. Don't start it. Dr. Agarwal, can you please share the screen in presentation mode?
Just a second. Sir, is it
No, it's not yet in the presentation mode.
just a second. Is it now, sir?
It is not yet in the presentation mode. Yeah, it is. Yeah, you can start your presentation.
Good morning, everyone. My name is Dr. Shwarya Agrawal, and with my respective guide, Dr. Sudhir Sera, sir, we have conducted a study titled Correlation of Fibrosis 4 Index with Carotid Edema Medial Thickness as a marker for subclinical atherosclerosis in patients with non-alcoholic fatty liver disease. In
2021, there was a meta-analysis which showed that the pooled prevalence of non-alcoholic fatty liver disease is somewhere between 36 to 38%, which is in Indian population. Initially, liver biopsy was the only mean to diagnose non-alcoholic fatty liver disease. But in recent times, certain non-invasive markers such as fibrosis 4 index has emerged as a potential alternative to liver biopsy to diagnose as well as to manage patients with non-alcoholic fatty liver disease. Why are we more keen about non-alcoholic fatty liver disease patients are because non-alcoholic fatty liver patients are more prone to atherosclerosis. There's a marker called carotid intima media thickness, which is shown to be a reliable parameter to detect it at subclinical level, which will help us to predict a risk of cardiovascular events. There have been various studies in past which has demonstrated strong validation between carotid intima medial thickness and adverse cardiac events, such as a study done by Vanden Oer et al. As well as Sun et al., who both demonstrated that one standard deviation increase in mean CIMT is positively correlated with the risk of adverse cardio events. Therefore, non-alcoholic fatty liver disease seems to be a mute spectator with a grave cardiovascular events, which help us undertake this study where we will study the correlation between fibrosis 4 index with carotid intimal media thickness as a marker for subclinical atherosclerosis in a patient with non-alcoholic fatty liver disease. After applying the inclusion and exclusion criteria, the inclusion criteria were the patient on OPD basis and or who presented to us in health checkups. Age was enrolled between 35 years to 75 years, and the exclusion criteria for the patient with uncontrolled diabetes of around more than 9, HbA1c, chronic liver disease, chronic kidney disease, and also with the patients with the EGFR less than 90, and the patient with metabolic disorders such as Wilson's disease and hemochromatosis. The exclusion and inclusion criteria were taken from the ELIF trial, and after applying these criteria, all patients with ultrasonography findings were suggestive of fatty liver disease were enrolled in the study. CIMT thickness was measured using an ultrasonic device, and the cutoff was taken to be around 0.9 mm. Fibrosis 4 index was calculated with the formula H into aspartate transaminase divided by platelet count multiplied by square root of ALD, with the high risk suggestive FIFO score more than 3.25 and the low risk fibrosis 4 index less than 1.45. In a study, we enrolled around 112 patients, out of which male population was higher, and the greatest number of the patient has grade 1 fatty liver on ultrasonography. We found it that the CIMT was, that is carotid intima medial thickness, was higher in grade 3 compared to grade 2 and grade 1, and this was statistically significant. We also found that the fibrosis 4 value was directly proportional to the carotid intima medial thickness and was statistically significant. To validate our finding further, when we went through the literature, we found out that the studies carried out by Rasool et al. Documented that as the grade of fatty liver increases, carotid intima medial thickness increases. Also, the study done by Arai et al. Recorded that CIMT expanded as liver fibrosis degree is increased with both histopathologically and with fibrosis 4 values in 195 biopsies proven non-alcoholic fatty liver disease. So the study established the significant correlation between the fibrosis 4 index and the carotid intima medial thickness in a patient with non-alcoholic fatty liver diseases, highlighting the potential of fibrosis 4 index as a useful marker in subclinical atherosclerosis. This relationship underscores the importance of monitoring liver fibrosis in non-alcoholic fatty liver disease, not only for hepatic outcomes, but also for the cardiovascular risk assessment. Early identification through such non-invasive markers can facilitate timely interventions and potentially improve long-term cardiovascular health in this set of population. Thank you.
Thank you very much, Dr. Agarwal. I'm told there is slight change in the pace as there is, in the interest of time, we are not taking any questions. I'm really sorry. But you can be rest assured, all these abstracts were submitted and evaluated by eminent judges, and we would announce the results of them. So now I would call upon Dr. Agarwal stay back. I would like to call Dr. Mohidur Rahman
and Dr. Bijish also into the Zoom meeting, just before I announce the results. Bijish, yeah. Rama. There's a phone guy. Sorry. Aishwarya has gone. Aishwarya, what can you tell her? Admit. Mohidul Rahman. What's happening, Mohidul Rahman? Okay, we'll go ahead and announce the results. Like you said, these three, not three, all the abstracts which are submitted were evaluated by the judges, and the third prize goes to Dr. Bijish, whose study was on a cross-sectional study on thrombolysis and ST elevation myocardial infarction and its assessment. Please give a round of applause for third prize winner. And the second prize goes to Dr. Mohidul Rahman, who just now couldn't join, so we will let him off. And the first prize goes to Dr. Aishwari Agarwal. Well done. Okay, thank you very much. You guys can leave. Your segment is over. Jagpreet Kaur. Welcome, Dr. Jagpreet Kaur. Can you hear us?
Yes, sir.
Can you please share your screen and then we'll start the timer?
Yes, sir.
First of the three presentations in DNB obstetrics is by Dr. Jagpreet Kaur, who is from Mata Kaushalya Government Hospital, Patiala, Punjab, and she did her dissertation under the guidance of Dr. Mamta Rani. Over to you, Dr. We go into presentation mode, please.
Yes, sir.
You can start your presentation now.
Okay. Good morning, respected judges, faculty, and colleagues. I am Dr. Jagpreet Kaur, DNB OBGY resident from Mata Kushalya Government Hospital, Patiala, Punjab. Today, I will present my thesis abstract on a comparative study of spontaneous versus induced labor and their effects on maternal and perinatal outcome in low-risk population. Labor is central to obstetric as it may begin spontaneously or we may intervene with induction. While induction is life-saving in conditions like post-dated pregnancies, but it is also associated with prolonged labor, higher cesarean rate, and maternal morbidity. In contrast, spontaneous labor always align with the nature's physiology and is generally safer for mother. But in low risk population, evidence comparing the two is inconsistent, especially in the public health setting in India. The gap in knowledge inspired my study. Objective of this study is there are mainly three objectives. First is to compare the duration and progress of labor in the spontaneous and induced labor group, to compare the mode of delivery in the two groups, and to compare the maternal and perinatal outcome between spontaneous and induced group. Method, it was prospective comparative study comprising of the 300 low risk women, out of which were divided into the two groups, 150 into the spontaneous labor and 150 in the induced labor group. Inclusion and exclusion criteria was followed. Term live fetus between 37 to 41 weeks with no maternal and fetal comorbidity was included. Previous cesarean, high risk pregnancies, malpresentation, and malpositions were excluded. Labor was monitored with WHO partograph and Bishop score was calculated. Data was analyzed with SPSS software. Maternal outcomes, it was found that induced labor had significantly longer latent and active phase. In latent phase, in induced group, it was average 11.9 hours versus 6.3 hours in the spontaneous group. Active phase was 3.5 hours in the induced labor group and only 2.6 hours in the spontaneous group. Oxytocin augmentation was needed more in the induced group, 53%, and only 15% in the spontaneous group. Mode of delivery cesarean rate was definitely more in the induced group, 25% as compared to spontaneous group, 5%. Normal vaginal delivery was more in the spontaneous group. Maternal complication like tachysystole, fever, exhaustion was more in the induced group. Perinatal outcome, in perinatal outcome, it was found that neonatal outcomes were comparable in both the groups. APCAR score showed no significance difference. NICU admission was comparable in both. Birth weight was more in the induced group, 2.94 and 2.76 kg in the spontaneous group, but it was not clinically significant. Overall, neonatal outcomes were comparable. To conclude, our results were striking. Induction almost doubled the cesarean rate and significantly prolonged labor. Maternal complications were higher, yet neonatal outcomes remained comparable, reflecting that induction is safe but not benign. The clinical message is clear. In low-risk pregnancies, spontaneous labor ensures better maternal outcome, while induction should be used only when clearly indicated. The findings also echo with the WHO and ACOG that says that spontaneous labor first, induction only when clearly indicated. Individualized care, shared decision making, and judicious use of induction will optimize the result. Thank you.
Thank you very much, Dr. Jakpreet Kaur. Again, in the interest of time, we are not taking any questions, but your abstract has already been assessed by judges. We will reveal the results at the end of the session. So please stay back in the waiting room. We'll call you again.
Thank you.
You can leave now. Next presentation is by Dr. Kripali Intalia from Sri Balaji Action Medical Institute, New Delhi. She did her dissertation under the guidance of Dr. Renu Gupta. Dr. Kripali, are you online? Dr. Kripali? Can you share your slides, please, in presentation mode?
Yes, sir, I am visible.
Your presentation is not. You are visible.
Wait, sir. Sure.
something is happening, and
Yeah, sir. Is it
you need, no, your presentation, yeah, go into full presentation mode, please.
Yeah.
Go to the first slide as well.
Yeah. Is it
Yeah.
visible?
Yeah, you're good to go. Yeah.
Yeah, okay, sir. Good morning, everyone, respected teachers and my colleagues. Today, I will be presenting my study that is ultrasonic assessment of cervical length at mid gestation in predicting the preterm birth. The study was conducted under my guidance of Dr. Redu Gupta at Sri Balaji Action Medical Institute. The introduction was preterm birth is defined as a childbirth occurring at less than 37 completed weeks counting from the last day of menstrual period. Preterm birth is not only the risk factor for perinatal morbidity and mortality, it also leads to adverse outcomes like cerebral palsy, retinopathy, learning disability, etc. Cervical length in a woman with a history of prior preterm birth is recommended by the ACOG. It still remains the controversial whether universal mid-gestation cervical length screening should be used as a strategy among the women without prior preterm birth. The ability to identify women at a high risk for a preterm birth could allow for a patient to undergo targeted interventions such as transfer to a higher center, antenatal corticosteroid administration, and a tocolysis, which might improve the perinatal outcomes. Hence, we have designed our study to assess the value of cervical length as a predictor of preterm birth in an obstetric population. The aim was to study the role of ultrasonic measurement of cervical length at mid-gestation in predicting preterm birth. The objectives were the determine the mean cervical length at mid-gestation by transvaginal sonography and its role to measurement as a prediction of the preterm birth. Materials and methods. It was an observational study conducted at the Department of Obstetric and Gynecology at Sri Balaji Action Medical Institute, New Delhi. There were 96 participants and inclusion criteria are taken pregnant women with age at 18 to 35 years with a single live intrauterine pregnancy in mid gestation at 16 to 24 weeks with a booked and registered pregnant woman and willing to participate, follow up and deliver in the institute. The exclusion criteria are the multiple gestation, fetal demise, uterine malformation, previous history of cervical treatment, and the risk factors for the preterm labors like severe preeclampsia, eclampsia, and severe IUGR. Women who will need elective termination because of obstetrical region in the advancing gestation will also be excluded from the study. The cervical length measurement by the transvaginal ultrasonography noted the women were followed till the delivery and the gestational age at the time of delivery will be noted and the data will be was analyzed and by the using chi-square test. Demographic and clinical profile, this 96 women were enrolled. The mean age is 28.7 years. Majority included in the 28 to 32 years. Gravida distribution, primary gravida at 47% and multigravida 52%. Cervical length distribution, more than 30 mm in 70%, 25 to 30 mm cervical length in 25%, and less than 25% in 4%. Gestational age at the time of delivery, there are 60% delivered by term and 34% in late preterm and 5% in early preterm. Mode of delivery, about one-third women delivered by full-term vaginal delivery and one-third by cesarean delivery, and rest were delivered by preterm delivery. Correlation findings, there was no significant correlation between the cervical length and the gravida, but there is highly significant correlation between cervical length and the gestational age. The women have more than 30 mm cervical length, who mostly delivered at term, and those women have 25 to 30 mm was delivered by late preterm or a preterm delivery, and all the women were less than 25 mm cervical length delivered by preterm. Cervical length versus there is also significant correlation between the cervical length and the mode of delivery. More than 30 mm cervical length mostly delivered by full term, and the less than 30 mm strongly associated with the preterm delivery. To summarize the result, Cervical length measurement at mid-gestation via transvaginal sonography is a valuable tool in predicting preterm birth. Shorter the cervical length significantly correlate with higher risk of preterm delivery, and routine screening allows for early identification of at-risk pregnancy and can guide timely interventions like progesterone therapy or a cerclage. Despite normal average cervical length, stratification and follow-up are essential for a risk management. Incorporating cervical length screening into the standard antenatal care can improve maternal and neonatal outcomes. Further research is needed to refine thresholds and explore combined predictive models using biomarkers. Now coming to the implication of our study, there is a transvaginal sonographic measurement of cervical length should be considered as a standard screening tool at the time of second anomaly scan to facilitate early detection and intervention. And future research should include a larger and more diverse population across the multiple centers to improve the generalizability and statistical power of the findings. Also, instead of the single mid-gestation measurement of cervical length, we can adopt the cervical length assessment over a time, multiple, so we can enhance the accurate predicting the preterm birth risk. Also, combining the cervical length with the biomarkers such as fetal fibronectin and maternal inflammatory markers, so may improve the precision of the preterm birth risk prediction. And the woman identified with a short cervical length should be considered for the preventing strategies such as progesterone therapy, cervical cerclage, and increased antenatal surveillance to reduce the incidence of preterm birth and benefiting both families and healthcare system. Thank you.
Okay, thank you very much, Dr. Kripali. Again, there won't be any questions at this stage, but please, we'll let you go back into the waiting room, and you can just join us when we announce the results.
Okay, thank you.
Next person is Dr. Ramay. Next speaker is Dr. Ramai from Vijay Hospital, Chennai. She did her dissertation on the guidance of Dr. Mala Vijay Krishnan. Dr. Ramai?
Yes, sir.
Can you please share your screen and go into full PowerPoint presentation?
Yes. Is the screen visible?
No.
Sir, I have shared the screen, sir.
Well, it's, yeah, just hold on a sec.
Sir,
Yeah, network connection may be an issue, but anyway. Sorry, go into full presentation mode. Are you in full? Okay, now we can see. Yeah, you can start your presentation, doctor. Your audio is, sorry, Dr. Ramay, your audio is not good. Okay, disconnected. There is a problem. Oh, looks promising. Yeah, go ahead. Please share your screen.
now, sir.
Still your audio is not very clear and your screen is not seen. It was seen last time. The other suggestion is probably keep the screen and then speak over phone in audio. Can you do that?
Yes, yes.
Okay, go back to what you did last time. Oh, no, she'll have to do share the screen and do the presentation. Yeah. Please share your screen and then you speak over phone probably. Mute the Zoom thing and then speak over phone. No, she's the last one of the three. Yeah. And there are only three presentations. This is the third presentation. No, it is not fine because you'll have to announce the results. Yeah. Yeah. Dr. Ramai?
Sir, visible now, sir.
Your audio is still not good. So please, via Zoom, you only do the presentation and probably speak over phone.
Okay, sir.
Share your screen, please, in presentation mode. Okay.
Shall I start?
Dr. Ramai, if you can't project the slides, maybe talk through your slide and we'll just listen to your audio. Or switch off, yeah.
Sir, is it visible now, sir?
Yeah, okay, go ahead. Let's see what comes up.
My study is of study of serum uric acid and low papillary level to 14 weeks of gestation with development of stage diabetes.
Dr. Ramai, sorry, Dr. Ramai, you'll have to switch off the video and keep only the audio in Zoom because probably it's a bandwidth problem.
Yes.
Switch off the video
Okay.
and keep only the audio and see whether that works better.
Yes, sir.
Yeah, it's much better.
So,
Yeah, now talk through the presentation.
it is pregnancy and has a high prevalence of 35% worldwide and in high prevalence of diabetes
Okay, Dr. Ramai, it's okay. I think this is probably not going to be working. We'll skip that. We'll announce the results. Just stay in this thing because it's already been judged. It's just an opportunity for you to share that information via Zoom. So that it's fine. You can just get the other two also in the. Dr. Kripali, and then Dr. Jagpreet Kaur. Okay. For the DNB obstetrics and gynecology abstract submitted, the third prize goes to Dr. Jakpreet Kaur from Mata Kaushalya Government Hospital, Patiala. And the second prize goes to Kripali Intalia from Sri Balaji Action Medical Institute. And first prize goes to Dr. Ramai from Vijay Hospital. So with that, we conclude the session.
Thank you.
Okay. Thank you. Thank you, folks. You can leave now. Just close. Ticket. And next, we move on to the section on DNB orthopedic abstracts. First of these abstracts will be presented by Dr. Tamil Kumaran from Ganga Hospital, Coimbatore. He did this, his dissertation under the guidance of Professor Rajasekharan. Oh, sorry. That I showed initially, but I can just call back again. Shall I do it at the when I do the presentation, the final price test? Because we've already called him. His connection is there over the side. Dr. Tamil Kumaran. Can you share your slides, please? In full PowerPoint mode. Yeah. Going to
is it visible, sir?
Yeah, your presentation is visible. Going to full PowerPoint presentation. Yeah, good. You're good to go.
Can I start, sir?
Yeah, you can start. Yeah.
Good morning to all. I am going to present on analysis of clinical radiological factors associated with the recurrence of giant cell tumor following surgery in the appendicular skeleton. Giant cell tumor is a benign aggressive disease, affects the invasive metaphyseal region of the bone. It accounts for 5 to 10% of all primary bone tumors. It commonly affects in the young adults with 20 to 40 years of age group. This is a 23 years old male with biopsy-proven giant cell tumor. He underwent intralesional curettage with bone cement application. In first year follow-up, he had a recurrence with previous studies shows local recurrence after intralesional curettage with variable recurrence rate from 2.5 to 65%, which comes to a range. What is the rate of local recurrence after extended curettage, and what are the risk factors for local recurrence after curettage? This study is a retrospective cohort study done in Ganga Hospital from 2017 to 2023. Our inclusion criteria are operated cases of biopsy-proven giant cell tumor in the appendicular skeleton between January 2017 to December 2023, and cases with all preoperative imaging. We excluded the cases of giant cell tumor in the axis skeleton like spine, sacrum, and patients with inadequate available imaging, and patients who lost to follow-up, and cases presenting with recurrence with primary surgery operated elsewhere. From January 2017 to December 2023, we operated 197 cases of giant cell tumor of the long bones, in which 53 patients had a wide section megaprocess replacement. 144 patients had a intralesional curettage with a high-speed burr and phenol and hydrogen peroxide as adjuvants, and defect has been filled with cement with or without allograft with sandwich technique. With mean follow-up of 53 patients, 53 months, we had 140 cases in the study group. These cases are analyzed under the factors: age at the time of diagnosis, gender, location of the tumor, recurrence-free interval from the primary surgery, and risk factors like Campanacci grade, soft tissue extension of the tumor, and filling of the defect with the allograft or cement, whether it is associated with the pathological fracture. On analysis, out of 140 cases, 95 patients are male, 55 are female. Most commonly affecting age group is second and third decade of life. Based on location of the tumor, proximal tibia and distal femur are most commonly affected, followed by proximal humerus, followed by proximal femur and distal tibia and distal radius. On Campanacci grade, we had 5 patients in grade 2. We had 88 patients in grade 2, out of which 13 patients had recurrence, 47 patients in grade 3, out of which 11 patients had a recurrence. So out of 140, 24 patients had a recurrence, which shows recurrence rate of 17.1%. With the individual variables, soft tissue involvement and Campanacci grade has a significant p-value, which shows high association with the recurrence of the giant cell tumor. All the recurrences, most of the patients had a recurrence within first 2 to 3 years of the primary surgery, with the mean recurrence-free interval from the primary surgery 3.3 years. Coming to discussion, this is a landmark paper on the risk factors for recurrence of the giant cell tumor, which study of 118 patients with 25% recurrence rate, which shows age of onset of disease is the significant factors influencing the recurrence. This another study shows pulmonary metastasis in the giant cell tumor as high association with the recurrence of the giant cell tumor. But our study shows there is no association between pulmonary metastasis and recurrence of the giant cell tumor. This is another study done in 2016, which with the recurrence rate of 36% with the filling of autograft or cement or allograft. There is no association between recurrence of the disease and filling of the defect, which is comparable with our study. This is another landmark study in 2016 with 179 cases, which shows strong association between soft tissue extension and recurrence of the giant cell tumor. Following intralesional curettage, which is comparable with our study. Our study has a recurrence rate of 17.1% with strong association between soft tissue involvement, Campanacci grade 3, and proximal femur as anatomical site is the individual risk factor for recurrence of the disease. Coming to conclusion, overall recurrence rate is 17.1% after extended curettage. Strong predictors for recurrence is soft tissue involvement, higher Campanacci grade, and proximal femur as anatomical site. There is no significant role in association between the recurrence and age at the time of diagnosis, gender, tumor site other than proximal femur, pathological fracture, filling of defect with allograft or cement, whether there is pulmonary metastasis or not. And shorter recurrence-free interval shows there is most of the patients had recurrence in the first 3 years of the primary surgery. So it needs meticulous post-operative follow-up protocol help in diagnosing if there is a recurrence of the disease. And if there is any risk factor for the recurrence, we can plan for wide resection, then intralesional curettage, considering the high rate of recurrence, local recurrence of the giant cell tumor following the curettage. And I thank you for this wonderful opportunity. Thank you, sir.
Yeah, thank you very much, Dr. Tamil Kumaran. Please stay back in the waiting hall. We'll call you back again when you announce the results.
Thank you.
The next person we'd call upon to present is Dr. Aravindan, yes, again from Ganga Medical Center, Coimbatore. He did his dissertation under the guidance of Dr. Rishi Khanna. Dr. Aravindan. Dr. Aravindan, please share your slide in presentation mode, please. You can see your slides. You'll have to move to presentation mode. Yeah, you can start. No, your audio is, you'll have to unmute yourself. Sorry, go back to the first slide, unmute yourself. Yeah. Dr. Aravindan?
Yes, sir.
Okay, fine. Can you go into presentation mode? Yeah.
Yes, sir.
Yeah.
Good morning, everyone. I am Dr. Aravindan from Ganga Medical Center and Hospital. Today, my presentation will be on appropriateness of MRI scan in spinal disease, its indication and clinical radiological relevance. Magnetic resonance imaging is considered as the most important investigation tool in spinal disease as it provides accurate anatomic information of spinal cord and column. It is essential for diagnosis and evaluation of the patient. It also helps in reducing anxiety by providing reassurance to both patients and treating physician. Because of its easy availability, the usage of magnetic resonance imaging increased over last decade. Sometimes the MRI were ordered in order to compensate inadequate physical examination to provide reassurance to the patients or on patient demands. However, the guidelines recommend the use of MRI in patients with red flag signs or patients with neurological deficits. This leads to a concerns of overuse of MRI imaging. Overuse of diagnostic imaging increases stress on radiologists and radiographers, increases workload on the radiologists, which can lead to defective reporting, and it also causes an economic burden to the society and leads to psychological stress to the patient who reads the report. The aims of the studies were to analyze whether clinical diagnosis matches the MRI findings, whether MRI findings influences the treatment plan, and to measure the MRI usefulness in patients with yellow flag signs, and to find the incidence of normal or clinically irrelevant MRI in patients with red flag signs, and to find the diagnostic yield of MRI performed on patient request. This was a prospective study conducted at Ganga Medical Center from January 2023 to July 2024. The study sample size included 460 patients. Patient visiting spine OPD, on patient meeting the inclusion criteria, the consultant fills a questionnaire. Each patient clinical findings and treatment plan was documented before MRI scan was ordered in order to avoid bias. After the MRI scan was ordered, the consultant documents the MRI findings in the second part of the questionnaire, and these data were entered into the Excel sheet in a systematic way and analyzed using a statistical software. The key analysis include: we compare clinical findings with MRI diagnosis and assess whether MRI influences the treatment plan, and also identify the situation leading to possible overuse of MRI. We included patient presenting to spine outpatient department with complaints of axial low back pain, radiculopathy, or any neurological deficit for whom MRI scan has been ordered. And we excluded patient not meeting this criteria or any contraindication for MRI, like presence of metallic implants or any pacemakers. Now coming to the result, out of 460 patients, our common age group we encountered was 40 to 60 years, and with mean age of 48 years, with no gender distribution, and the most common symptoms are low back pain and radiculopathy, which accounts for 35% of the patient, and more than half of the patients has red flag signs at the time of presentation, and 87% of the MRI were ordered in order to confirm the diagnosis. Looking at the indication for MRI, if MRI ordered for the general evaluation of spinal complaints or in order to confirm the diagnosis, has a significant finding in 83% of the patient and 78% of the patient respectively. But MRI when ordered at patient request or for other reason has a significant value only in 7% of the patient and less than 8%, less than 1% of the patient, which indicates the potential overuse of MRI in clinical practice. And this prolapse and lumbar canal stenosis is the most common MRI findings that coexist with initial clinical suspicion. There is a strong diagnostic alignment of 70% between clinical and MRI diagnosis in our study. And MRI helps in guiding or changing the treatment plan in 70% of the cases in our study. Out of 240 patients with red flag signs, that is clinically irrelevant or normal findings only in 10 patients of the patient, which contributes around 20%. This emphasizes that MRI is useful when guided by red flag symptoms and careful clinical assessment. To conclude, MRI is a valuable tool but should be used judiciously. Overuse adds cost and anxiety without improving the outcomes. There is a strong diagnostic alignment between clinical signs and MRI results and limited utility of MRI in patient-driven cases. And there is strong correlation between patient with red flag signs. Clinical history and examination remain vital in guiding imaging decision, and educating clinical and patient on evidence-based MRI indication benefits the society and should be reserved for where it can aid in diagnosis or treatment of planning to ensure optimal use of resource and better patient outcome. Thank you.
Thank you, Dr. Aravindan. Please go back and wait in the Zoom waiting hall, and we'll call you back when you're announcing the results. Next speaker is Dr. Naveen A. From, again, Ganga Hospital, Coimbatore. He has done his dissertation under the guidance of Dr. Devendra. Dr. Naveen? We can see your cat. You also should show up soon. Okay, good. Can we go into presentation mode, please? Yeah, the presentation mode. Yeah, you're audible, which is good. Can you go into presentation mode? Yeah.
Shall I start, sir?
Yeah, that's fine. Go ahead.
Yes.
Good to go.
Good morning to respected chairpersons, distinguished judges, esteemed faculty members, and my colleagues. Myself, Dr. Naveen A., final year postgraduate in DNB Orthopedics from Ganga Hospital, Coimbatore. I am presenting the study of intercomponental effect of Ganga Hospital Open Injury Severity Score on salvage and amputation in open injuries of lower limb with the total score of 10 and above. As we all know, our Ganga Hospital Open Injury Severity Score has 4 major components with the skin and the covering structure, functional tissue unit, that is the musculotendinous unit, muscle unit, and the skeletal structure. Each of these having 5 as the major component, 5 as the maximum score and 1 as the minimum score. With the 7 comorbid conditions, each having 2 points. It is the most sensitive and specific score of open injuries of lower limb for salvage and amputation in the available literature. When the score is 14 and below, the limb can be salvaged. When it is 17 and above, the limb is amputated, and 15 and 16 are in the gray zones. The intercomponental effect of individual components of Ganga Hospital Open Injury Score, Severity Score is not being studied. Hence, our aim is to study the intercomponental effect, that is the skin, musculotendinous unit, bone, comorbid conditions on salvage and amputation in open injuries of lower limb with the total Ganga Hospital Open Injury Severity Score of 10 and above. After obtaining ethical clearance, the study was conducted at Ganga Hospital. It is a combined retrospective and prospective study. The data were collected from January 2018 to December 2023, which included the patients above the age of 18 years with type 3 and 3B open injuries with Ganga Hospital Open Injury Score of 10 and above, and excluded patients below the age of 18, initial debridement done at another hospitals, type 1, 2, 3C open tibia fractures and open injuries with follow-up less than 6 months. Total of 200 patients were analyzed. Bivariate relationship between the methods of treatment, that is a salvage and amputation, and multivariate regression models were then used to identify the factors predictive of decision of the treatment. 71% underwent salvage and 29% underwent amputation, with the majority male is 90% and female is 10%. This table shows when there is a total score of 14 and below, almost all the limbs underwent, majority of the limbs underwent salvage. When the score is 17 and above, almost all the limbs underwent amputation. And when it is 15 and 16 in the gray zone, 21 underwent salvage and 27 underwent amputation. This signifies that the reliability of Ganga Hospital Open Injury Severity Score in decision making as the score increases. On analyzing the individual components, the skin and the covering component, skeletal structure, functional tissue unit, comorbid conditions separately, we found the statistical significant value for skin and the skeletal structure is 5 for amputation, and for functional tissue it is 4 and above, and comorbid conditions with the presence of 3 or more comorbid conditions, that is 6 and above, is statistically significant for amputation, and the scores below which are significant for salvage. The combined score of skin and bone, skin and muscle, skin and comorbids, muscle and comorbids, bone and comorbids, and the bone and muscle are also studied, and which gives the statistical results. On logistic regression analysis, the individual components and the combined components has individually given statistical significant results for salvage and amputation, with the functional tissue score being the most significant score over the other scores. The functional tissue score, when it is 5, all patients in this subgroup underwent amputation, and covering component, when it is 5, majority ended up in amputation. The severe skeletal involvement, that is the score of 5, is strongly associated with amputation in the gray zone group. Even when the total score is 14 and below, with the skeletal score of 5, when the other scores are statistically significant for salvage, the limb can still be salvaged and bone gap management can be done in later procedures. When compared to the lower score. Age more than 65 years within the Ganga Hospital comorbidity component showed higher risk of amputation The progressive rise of Ganga Hospital score correlated linearly with the higher amputation rates across all the components. So we concluded with the functional tissue injury severity is the most decisive factor. Higher score invariably led to amputation. When the covering component is 5 and the skeletal score is 5, it carries a poor salvage prognosis. The comorbid conditions with the Ganga score raises, the amputation rates raises. Age more than 65 years contributes to poor salvage outcome, but should not be a definitive criteria for amputation. Hence, the systematic application of Ganga Hospital Open Injury Severity Score allows evidence-based decision on limb salvage versus amputation. These are my references. I thank my guide, Dr. Devendra sir, and my family, and Dr. Deen Dayalan sir and Professor Rajshekharan sir for continuous support, and ANBAI for giving this wonderful opportunity to present my thesis topic. Thank you, sir.
Okay, thank you very much, Dr. Naveen. Please stay back. We'll call the other two as well. Just we announce the results. And share my.
Thank you, sir. Yes, sir.
All I can say is, although the entries were there, the judges were from different institutions, which is why I'm going to project that. Can you do the slide share of my second presentation? No, don't put. Okay. Yeah, go back to the slides. Can they be there? Can the three be there? Put all three of them. Presentation of the second one. This one. Yeah. Leave it at that. Yeah, and then can you call them? Three of them. Anyhow, Google. Naveen, Aravind, all three of them. Admit all of them. Yeah. And the other also. Hello. Is Dr. Tamil Kumaran, Aravindan, and Naveen on line?
Yes, sir.
All three of you?
Yes, sir.
Okay, that's fine. This is for the audience here. Sorry, I assume I just want to quickly recap the judges who judged all the abstracts. For medicine, it is Dr. Himanshu Bateja from Sri Balaji Action Medical Institute, New Delhi. Professor Balaraju from Yashoda Super Speciality Hospitals, Hyderabad. Thank you, sir. And Dr. G. Rangaprasad from Vijay Hospital, Chennai. Assuming that there may not be questions, I had just prepared for an interlude question. Quiz question. But anyway, you guys most of you may recognize this famous son of Bengal, whose birthday we celebrate as National Doctors' Day. I learned a lot about him along the way. The judges for the DNB Obstetrics and Gynecology thesis abstracts were Dr. Aarti Singh from Regency Hospital, Kanpur, Dr. Niranjana from Vijaya Hospital, Chennai, and Dr. Bhagya Lakshmi from Yashoda Hospital, Secunderabad. For orthopedics, although the presentations were all from a single hospital, the judges were from other hospitals. Professor Dr. Sivakumar from Preeti Hospitals, Madurai, Dr. Sunil Kumar from Sri Balaji Action Medical Institute, Delhi, and Dr. Krishna Subramanian from Hyderabad. So, and they followed the structured evaluation tool which we had created specifically for this purpose, and so it was as unbiased as it could be. With that, I would now announce the results of the last section. So the third prize goes to Dr. Tamil Kumaran. Please give a big hand. Second prize goes to Dr. Aravindan, and first prize goes to Dr. Naveen.
Thank you.
Score, yeah. So this is Dr. Naveen, who were the first prize winners, and the other two are also there, actually. Okay, well done, guys. So best wishes, and with that, we close the session.
Thank you, sir. Thank you, sir.
Thank you very much for bearing with us despite the technical glitches, which were way beyond the control of what I could do. But thank you very much for the IT team. And yeah, thank you for all the judges once again. Great.
Thank you, Dr. Ganeshan. Very wonderful program. In spite of the small technical problems, you have done a very good job, and we are very happy. And I think we'll next year will continue in a best way and bigger way. Now, I welcome Dr. Uh, Babutosh Biswas sir and Dr. Balaraju sir, Alumni Coordinator, Dr. Bipin Chawla, President Mumbai Maharashtra Chapter, Dr. Carol, Secretary Karnataka Chapter, and Dr. Rajesh, Joint Secretary from Ahmedabad, Gujarat Chapter. I think we are a little bit behind the schedule. We will break for the tea, but tea we thought half an hour, within 15 minutes we'll complete it and come back. Thank you. Thank you. We'll break for the tea.
Friends, on behalf of Tata Medical Center, Kolkata, I warmly welcome you.
Would we be forced to do an FRCS, which is called like a forced retraction and a continuous suction? You will be operating at the end.
To encourage them to engage in. Okay, thank
Okay.
Conducted Ganga Medical Center from January 2023 to July 2024. The study samples is included 460
curettage, and what are the risk factors for local recurrence after curettage? This study is a retrospective cohort study done in Ganga Hospital from 2017 to 2023. Our inclusion criteria are operated cases of biopsy-proven giant cell tumor in the appendicular skeleton between January 2017 to December 2023, which shows age of onset of disease is the
48 years.
7
Phase in induced group.
Started with, we finalized this flyer, competition flyer around April time. As you could see,
Friends, on behalf of Tata Medical Center,
Less than 90.
Sensitive and specific score of open injuries of lower limb.
Phase in induced group, it was
Logistic regression analysis, the individual
Hospitals, Hyderabad. Thank you, sir.
and Dr.
And Dr.
and avoid common pitfalls. So the best practices in how to write the thesis and the abstract. So why does it matter? Why is it essential to learn this art, and why is it at all part of your curriculum? It is important so that obviously there is a framework within which you need to operate and complete your degree requirements. But apart from that, a thesis, the purpose of a study or for a research or a formalized research in the form of a dissertation is to enhance critical thinking and methodology expertise. So when you do the thesis, unless you do it, one thing is reading and you're appreciating a paper, and the second is knowing how that paper was, how the authors went to the completion and finally wrote up that paper, right? So you need to have critical thinking, a deep understanding of the methodology so that you know how best and how ethically and how scientifically to conduct the research. And research is in fact something, so what you're doing now is what was researched or what was studied a decade back. So it connects the daily practice with research, and so the bridge is the dissertation where you formally present your research findings. And obviously as an academician, it is important to publish, and it is important for your academic progression. And for those who will not be within academic practice, it is also essential because knowingly and unknowingly, whatever you're doing to your patients or whatever you're prescribing to your patients, in today's day and age has to be backed by evidence. And when you apply that evidence to practice, you should know how that evidence came and how best or how it could have been done better, so that you know whether that's applicable for your patients or not. So the NBMS thesis protocol will serve as so the protocol is an operating manual. So when you go about in your lab practice, if for those who are in the lab, you know that there is a written out protocol for a test, and you follow that protocol. So your protocol is supposed to be that lab manual which you follow to do your scientific study. So basically, as NBMS requirement, it is important that you have any study will have a title. It should have a synopsis. And why is synopsis important? Because it is important that you can summarize your work within a short span of time. Because the first target audience who will read you submit an abstract, right? Wherein the R&B or the board expects you to summarize your work within 300 words. Now, it's easier said, but when you write, you see that you cannot fit your abstract within 300 words. Then you do a revision, you ask a mentor to go through it, and then he reduces it to 400 words. And it still doesn't come within 300 words. And then again you do, but actually when you submit, if you do submit within 300 words, you will see that it can be done. Because a lot of times, what we express, we think larger sentences are required to express your thoughts more clearly, but it's not. So abstract teaches you the art of summarizing your thought process within brief sentences, short sentences, and still come out with the weight so that within that 300 words, you communicate to the person who's reading it, who may be a layman not connected to your field of study, what and why you want to do and how you want to do your study. So the purpose provides a quick overview for the readers to assess the relevance. The length is 300 words. The structure I'll come to in the next slide, and audiences, researchers, clinicians, and assessors who may not be from your same domain. So classically, the structure that is followed is the IMRAD structure, where there is an introduction, there is a methods or methodology, there are results, and discussion. So, what you try to communicate is why was the study undertaken, which means you enumerate the research problem. How was the study conducted, which means what did you do or what you want to do. Then when you submit your results, so when you're, then what was found, what did you discover. And finally, the conclusion of the discussion, whichever is applicable, spells out how does it matter, whether it matters at all, and how does it matter. So you must recognize that sometimes when as residents or fellows, you will have an idea that it's desirable that your study has a positive outcome, which is actually quite wrong. Because you may be actually asking the question that this is a standard practice, and I want to audit my findings to see whether at all it's relevant. So in that context, even if you come out with a result that it is actually not making a difference, then you save the community or you save the patients from doing unnecessary tests or using unnecessary medicine. So please don't be biased when you're interpreting the results. So the IMRAD structure provides a universal framework that makes your research understandable to readers across different specialties and backgrounds. So the abstract structure as spelled out by NBMS covers a background or an objective within 1 to 2 sentences, a method within the next 2 to 3 sentences, results in 3 to 4 sentences, and a conclusion. And this is when you're submitting, right? When you finished it. So the best practices is that it should be clear, concise, yet precise and consistent. So basically, you will have to fit in your idea within short sentences. Avoid excessive adjectives and adverbs. No redundancy, so no repetition. And contemporary and relevant content. So if you have 10 references, please only highlight the most current reference and the most relevant reference. Additional tips: use active voice where possible while writing and not in passive sense. Define abbreviations, so it is always a good practice not to jump into abbreviations, because for you, who is writing it or who is well versed with that subject, that abbreviation may be your colloquial terminology, but for a reader, it may not always be. So somebody who is searching will always search by 1 or 2 keywords which may not be present in your abbreviation. So focus on data and not on opinions. Again, you can only conclude as much as you wanted to or as your data has. Don't go beyond. So in your conclusion, you cannot say something that you haven't studied, and include statistical significance only where it is relevant. So good abstract is a mini version of your paper with maximum information in a minimum space. So the common mistakes that are usually made while writing an abstract is that sometimes you fail to state the hypothesis clear, and it's important as part of your introduction, or you must spell out that this study intends to do this. Missing sample size information, again, this is important, because it is, if you're doing a study on 5 subjects versus you're doing a study on 50 subjects versus a study which you're doing on 500 subjects, makes a difference in the way the reader is going to interpret the results and see or have confidence in your data. Missing sample size information, it may or may not be present in the abstract, but at least in your paper it has to be spelled out. Results without numbers and statistics is not important. So if you say this was found to be significant, that doesn't make how you made that comparison, what is the exact value in terms of statistics that you used while making that conclusion, and using conclusions not based on study findings, as I pointed out earlier. Don't use long and complex sentences, so short sentences, ideally less than 10 words in a sentence. Technical jargons without explanation, because again, we sometimes tend to make the paper so complicated that it's difficult to read through, and that is not a paper which is cited more, because the reader will lose interest halfway through an abstract. Repetitive information should be avoided because it should be concise, precise, and within minimum number of words, and you should not make weak or vague conclusions that this test is good. How good, which population, which subset should be spelled out, right? So assessors can quickly spot these common errors, and also taking time to review and revise your abstract will significantly improve your chances of acceptance, and this is not for DRNB acceptance, but this is when you are sending it out for publication. So this is something, this may not be an ideal abstract, but this is something which we are going to submit as part of our DRNB thesis. So please don't take pictures, and this is not, this is something we've intended to, so we've just submitted. So basically wherein you're using a particular sort of therapy, so the title spells out as what is your cohort, what is your intervention, and what you're going to study. And this is 300 words, mind you, right? So you are also describing the problem and saying that you're using a particular line of therapy and you want to, and what exactly you want to study. Now you have defined the timeline, you have defined the expected cohort, the objectives, including the primary objective, and usually should be one primary objective, because based upon this, your study will be, your sample size will be chosen, and your study will be powered, or if it's just an analytical, it will be powered to answer that question. Secondary objectives can be more than one, but should be relevant to the cohort that you are studying. And what are your expected outcomes, because that is the relevance. And this is when you're submitting, prior to submitting a protocol. So that is your first step as part of abstract submission. Now when you're coming to thesis, when you've done a study, now you're sitting down and writing the thesis. The thesis components will start with a cover page, then will be a declaration, then an introduction. Now introduction is an important portion where you highlight what is already, what is known in general, and what is the context of your study. Then you review the literature to justify that introduction with relevant literature, citing references, and herein comes the importance of using good reference managers. So you should when you're starting or when you're doing your work, you should always save your references in a good reference manager, because then it becomes very easy to write. And this is something you should always do, because if you start doing that at the end, you're unnecessarily using up your time for unnecessary things. Then section will be aims and objectives. Now aims will be broad, or hypothesis will be broad, and then objective will be point. For example, so if I say I want to study the outcomes of treatment with a particular regimen X, then the objective is I want to study the post-induction remission rates after 3 cycles of regimen X. Wherein so the aim is broad, and the objectives is more precise, and you're defining how you're going to study that aim. Then is materials and methods, wherein you assess the 10 essential elements, and because of lack of time, I probably will not be able to go into that in detail. The results, wherein you analyze the data analysis and presentation, and have clear sections. And this is the most important part of your work. So you should always, when you start writing the results in a dissertation, you should always focus on what comes first. So you first describe the population, so baseline characteristics, demographics, including all those are relevant to your study population. Then for example, if you're doing an intervention, then, so what was the intervention, how much of the patients received the full planned intervention, what was the median dose of that particular intervention that the patient received. Then you first thing that you describe is the primary objective. So then devote some time in showing how you studied the primary objective, what were the results, and what was the outcome. Don't discuss it, don't make a conclusion. So results should be very straightforward, describing what you spelled out. No conclusions. Then go on to secondary objectives, 1, 2, 3, 4, whatever secondary objectives you have, and devote clear space. And so sometimes what we do is we have one full page of describing a bar chart and a pie chart on age and gender, not necessarily. Concise. So describe the age and gender and everything in a good table, because that's what you're expected to do. Don't spend unnecessarily. A fatter thesis is not necessarily a better thesis, right? So you should be concise. Then go on to the secondary objectives. Whatever you did not commit in your synopsis, but you did, you may exclude or write it as exploratory points and at last. Don't mix up. So primary, secondary, 1, 2, 3, and only then describe or something that you did which was not within that defined points. If at all you have to mention that. Then come to discussion. Again, discussion, your primary point is, so there are 2 ways you can write the discussion. If you're doing something that has never been done, then you have to describe what you found and how is it different from the data already known. Because ultimately discussion is the section that bridges the results to the conclusion. So you should describe, in scenario A, where you're doing something entirely novel, you will describe your findings and then how you think, in very scientific words, this is applicable to the standard of care practice that in future. So for example, if I'm studying a regimen X that has never been studied before, I need to describe regimen A, B, and C, which are standard of care. And then I need to say that for regimen X, I'm finding this. And if say, for example, it was safer, or it was, that was your primary objective, or it was more efficacious, then you say that so you describe that this is our objective, this is what we found, and this is what is present in regimen A, B, and C. However, if your primary objective was only to study that and so you did not have a control population, please don't go on to mention that I think regimen X is better than regimen A, B, and C. Because you didn't start to analyze the different regimens. So only discuss what you have studied. And then when you make a conclusion, say that this regimen X, in this particular set of population that was studied, was found to have a reasonably good or a good induction. And again, define that good induction in your introduction or your review of literature. Scenario 2 is wherein you are doing something that has already been studied. So then you mention that this has been studied before and what are the relevant points and what were their conclusions and what is your conclusion. And if it is same, then you say that it is similar. If it is different, then try to say that why it could have been different. Now don't make wild guesses. Whatever you mention is why you found that discrepancy could actually be the lacuna of your study, or could be because you're studying it in a different set which wasn't studied in those particular studies before. So be precise and don't jump the gun and say some things which is wildly speculative. And after discussion, come to summary. So summary is the final point wherein you summarize the most relevant findings. Forget about positive or negative. Each finding that you have got, which are relevant. So among the 20 findings that you have described in results, you describe 5 findings or 6 findings that are most important and which people should know. And then go on to conclusion, which should be a paragraph at most, brief, making conclusions from that summary. Again, relevant, and that has been studied. No speculation. And then put in references again. As I said, this big section becomes much easier if you're using a reference manager, and there are free reference managers available. So always when you're starting the study, right from the writing of your synopsis, you should start using your reference manager. And whenever you're in your daily practice or during the course of your work, you find relevant references, store it within particular sections so that it's easier for you to find, and then use that reference manager to cite the references. And finally, the appendix containing the forms, consents, and the protocols. Again, this spells out what should be the formatting requirements, which will be there, and the slides can be shared. So materials and methods, as I said, will not describe in detail, but the 10 essential elements will include the study setting, the study duration, the study design, and you need to understand each of them well. Study sample, the inclusion and exclusion criteria, the interventions, if applicable, if it's observational, then also what exactly is the background or the setting, the data collection, how you did the data collection, the outcome measures, primary and the secondary, relevant to that objectives, sample size calculation method. This is very, very important. And again, there are 2 steps at which you have to mention this. Once when you're writing the protocol or the synopsis, and the second when you're writing the dissertation. Please don't ignore it. Please don't be speculative. Please use the help of a statistician if you're not good at statistics in spelling this out, because an underpowered study or an improperly selected sample size is as good as no study, and your study will have 0 relevance in world literature, right? Data analysis and ethical issues surrounding the clearance, consent, and registration. Again, it is important that if you're doing a prospective study, you have a consent form and you do the consenting during the study, because again, an improperly or an unethically conducted research has 0 relevance in world literature. So results and discussions, the best practices is when you write the results as part of your thesis or dissertation, you organize it in sections, as I said, for clarity, because the one who is reading it should understand the flow of your work. There should be correct data analysis. So if you're not good at statistics, take the help of somebody who's good at it and always cross-check it with a statistician. And because there's always help at hand, he or she, the statistician may not be in your institute, maybe in some other institute, but it's always good to seek help. You should use appropriate charts and not excessive charts and diagrams, because excessively used diagrams can sometimes make it more dilute and the thesis more bulky, which is irrelevant. Objective reporting without interpretation, just the facts, and statistical significance only where relevant. The discussion section should start with the results summary in the text from, preferably. Compare with earlier research findings, whatever it is. If you're laying ground for a new protocol, then whatever background is known with respect to the different protocols. If you're studying the same protocol that's been studied before, then the relevant literature with respect to the ones that were studied before. Interpret the findings only in the context of the existing knowledge. Usually should be ones that are published, and try to avoid something that's been presented only once in some abstract conference with an improper sample size. That may not be the best literature to cite. Suggest future research directions only based upon your findings. So writing an effective conclusion, this is very important, because an abstract and the conclusion are the most scientific portions, and so it actually, by reading the abstract and reading the conclusion, a person can make out the effort or the clarity that has gone behind the study, and the clear sense of understanding that the author has with respect to the study. So you should restate the research problem in as short one sentence, the brief overview of the methodology, again plus minus, but summary of the main finding in 1 or 2 sentences, and conclusions only pertaining to the research finding and the result finding. So it should explain the significance and the implications, suggest an application, maybe what is the direction that your study leads to, whether your very new finding should lead to a study in a larger set, whether your study which has already been done in a large population during the study, because again, and in the findings are validated in a different research cohort or a different setting, so that this can be made standard of care practice. And or also if it is actually corroborating with the facts that's been there, so then you say that this practice is good, and we corroborate that, and it should continue. So this should remain a standard of care treatment. So your conclusion is the last thing that your readers will see. So make it impactful. Impactful doesn't mean snazzy, doesn't mean glamorous. Impactful means that line should highlight to that person who's reading it that this is what I should carry forward tomorrow. So when I stop reading this article, if there is one thing that I need to remember, this is what I need. This is what I remember. Again, as I said, ethics and quality assurance should be part, and I think I'm proud, as in TMC we take this very seriously. When you start your study, you should have an IEC approval. Preferably, the IEC from which you get an approval should be registered. You should not copy paste things, so there should not be plagiarism. Plagiarism, again, in today's day and age, has two connotations. One, in which you directly copy and paste from publications, and two is in which you use AI. Again, the way we look at artificial intelligence and the artificial intelligence language softwares in future will change. It will probably, the context may change from plagiarism to disclosure of interest, disclosures, but it's good to spell that out. And try to be as original as possible. Data confidentiality is important. So your Excel sheet should be encrypted. You should not download your Excel sheet and keep it unprotected in a public computer which everybody has access to, because ultimately, remember, you have committed to maintaining privacy for the patient and confidentiality of the patient. This is something which we take very lightly, but something which is very serious, because these are legal connotations. And I'm not sure about the laws in India, but outside India, you can lose your registration if you're very lax. Bona fide declaration signed by candidates, guides, and head of institute. The best practice for that IEC. The best practice is to choose feasible and economical and original topics. This is for when you're choosing your topics. You may not necessarily be doing something it's absolutely novel, but it's also not good to do something that's been wrote and been done, and you're just doing it for the sake of doing it. use contemporary and relevant literature. So don't go back 30 years and say that this was done 30 years back and whatever I'm doing is probably validating the findings of something that's done 30 years back, not relevant. Maintain scientific soundness throughout. Be very, so your literature, so that's an art of writing. The more you write, the more you publish. May not be always publishing, but the more you write your findings in a more scientific way, the more accurate you become in terms of writing. And it's a pleasure reading a well-written article. So there may be two types of good articles. One that has an absolutely novel finding but badly written, that may change practice but may be less cited. But always the papers that are better cited are very good written papers, very well written papers. So please go through citations, through papers which have been cited thousands of times, and see the language in which they've written the discussion and the conclusion. And follow established methodologies, which should be clinically established research methodologies, right? So common pitfalls at the protocol stage is not taking an ethical approval, not including consent, exceeding word limits, unclear objectives, which is very vague, inadequate literature review. At the time of writing thesis, poor formatting compliance, so being very descriptive, very generic, lots of things which are not required. Insufficient statistical analysis, because again, as you're making a conclusion without an appropriate statistical takes is as good as not making a conclusion at all. Conclusions beyond the study scope, so don't overshoot what you have studied, and missing essential declarations and conflicts of interest. At the stage of submission, again, most important is, the most common mistake that residents make is they don't do the thesis well, and they only wake up 1 month before, and then they summarize it and jumble it, and then they submit it late. So see, at the end of the day, that will be done, you'll be clear, you'll get the exam maybe, but you will not be true to your own self, and when you pass out, you will probably be at the same stage wherein you started. As I mentioned in my first slide, the purpose of doing a thesis is growing in your academic journey, and you will not be growing at all. And your juniors will learn from you. So you are doing disservice to yourself and to people who look up to you. Technical formatting errors should be avoided, and ignoring feedback. So if you give it to somebody, so always complete it in time, give it for somebody to read. They will give you feedback, and in a hurry, if you don't just forget those feedback and submit it, you may do that. But that's not doing justice, because that feedback will actually help you improve. And if you're interested and you're actually going back later and publishing it to a journal, it's very likely that like-minded peer reviewers will come back with that same review and may reject your article. So it's always good to take constructive feedback and include that, because ultimately the ones who give you good criticism, your biggest critics are actually your best friends and mentors. So follow those criticisms, and that will only help you improve your scientific acumen and writing skills. And so the difference in success and failure often comes down to attention to detail and following guidelines precisely. Guidelines are always there as a structure, but it's always important to be attentive to detail. So just as a pro tip, check the PDF that's been published by the NBMS. So these are the checklists and the email IDs mentioned over there. So if you have, the key takeaways from this talk should be that you should start early, follow the timelines, don't do it in the last day. Please write one paragraph. When you're writing your synopsis or your abstract, write one paragraph in 2 days. But start early, so that by the end of 2 weeks, you have a well-structured, thought out, because if you're writing on the last night at 10 o'clock and you're sitting, your mind is bogged down from already all the work, then you're mostly writing things which are silly. Structure matters. Use the structure IMRAD format and stick to it. Quality should be important over quantity, and I'll just give you an example. So some of you who will be relevant, knowing about chronic myeloid leukemia will be conversant with the Philadelphia chromosome, which is a translocation between chromosome 9 and 22. That discovery was highlighted in a letter to the editor in Nature. It was half a page of publication, and that is one of the most cited literature till date in the parlance of oncology. And it changed the survival of a disease from a dismal 20% to 90% survival at 5 years. So it's not important that you write foolish things in 20 pages, but very scientifically accurate things in a page. And actually a good quality can only be when you summarize and when you know that this is relevant and this is what my reader should read. So ethics comes first and foremost. You should only do research that is ethical, and that starts from writing the protocol, taking the consent, actually getting the consent signed, explaining it to the patient. Formatting, so adhere to technical specifications, because in the context of your thesis, the board may reject it. In the context of your submission to a journal, the journal may reject it. So most of the most common reason for a desk rejection in a journal is an improperly written abstract. Seek feedback from your peers, your friends, your juniors, your seniors, your mentors, and get the feedback and then correct them before submission. So your thesis is not just an academic requirement, it's your contribution to your own self and to the medical knowledge, and is the foundation of a research career. So if your foundation is weak, you will have difficulty in growing as an academician. So thank you for your attention, and so your research matters.
Thank you, sir. Wonderful presentation with full clarity. I hope that not only physically present here, people who are online will benefit you from your talk, and they follow ethical and quality and all those things. Now I request Dr. Barwa to honor our Dr. Arjit Nag with memento. Please, sir. Thank you, sir. Now, the next session is research is the engine that drives innovation, discovery, and progresses which directly impacts health, improves health outcomes, influence policy and translation of lives. Research should be relevant to the health needs of the population, and translation is bridging the gap between the findings and application or implementation of the research. Now we have panel discussion on making research more relevant and translational. The moderator is Dr. Indranil Malik, did his MD radiotherapy from PG Chandigarh and awarded gold medal also. Dr. Indranil Malik has keen interest in innovative educational technologies and leads 3 e-learning programs for oncologists that are available worldwide, including over 150 hospitals in India. He is member secretary of Ethical Committee. Now I request Dr. Indranil Malik to come to moderate the session. Please, sir. Now the panel members, please, sir, please come. The panel members, Dr. Jaydeep Bhaumik, HOD, Senior Faculty, Gynecological Oncology, Tata Medical Center, Calcutta. Dr. Somendranath Roy, HOD, Senior Faculty, Nuclear Medicine. Please, sir. Dr. Rosina Ahmad, Senior Faculty, Surgical Oncology from TMC. Please. Dr. Abhimanyu Khar, Consultant Gastrointestinal and Hepatobiliary Surgeon from Tata Medical Center. And Dr. Karol, Secretary ANBAI Karnataka Chapter from Baptist Hospital. Please join. Now I request Dr. Indranil Malik to conduct the session.
Dr. Shusri Roy Chaudhary and our hospital management for organizing this meeting. And a warm welcome to all the panelists in this, what I consider very interesting panel discussion. So I would like to start off with a very provocative statement. A few months back in a very prominent social media platform, one of the most respected physicians in the country, Dr. S.P. Kalantri, from MGIMS Wardha made a post, and he said, I'm reviewing another DNB thesis. And like the brothers, the MD thesis, I find that this is pointless, that I am reviewing hundreds of these theses. They don't seem to be related to the need for doing research, that we should really, really rethink whether research in these training programs in the form of a thesis is actually relevant. So the first point I would like to make is that we are discussing how to make it more relevant, but is it relevant at all? Or is research in the DNB, because we are in the ANBAI program, is research relevant, or is it just a formality that needs to be done to complete an educational program? And I have, several senior colleagues here. I'd like to start with Dr. Carroll. You are the only outsider, so I'll put you on the spot. So tell us what you think. And I think it's important, whether, no matter what we feel, to be frank in our assessment of the situation, because unless we discuss it, once we will never be able to improve a situation.
Yes, thank you very much. I would answer it in two phases. The first one, whether it is relevant. During the undergraduate level, what we are thinking is mug up, and then we are not critically thinking, mostly we are following. And when you're coming to the postgraduate, that's when we are telling them to think. Now critically look at it, ask a question, and then how to answer it. That is what we are teaching them. So it's like 20 years of education in one time, and then you're telling a different paradigm shift. Now this requires mature teachers, mature researchers in the ecosystem, and also when the students go through it, a hand-holding. Now in DNB centers, unlike medical colleges, mostly it is people practicing, coming and then seeing their patients and going. And they will be teaching them all other in terms of their clinical practice, but the whole ecosystem of some places will have ecosystem of research and that thinking of research, but other places they are just left to, even the teachers and the students are there without much of an ecosystem to support them. So the question, is it pointless? I don't think it's pointless. They have to understand science, and even if you do not do science, at least to understand, critically look at what science they should adopt. So that's very important. Second, now coming to the second question, whether it's relevant, irrelevant, we have to first give them an ecosystem before saying that it's like whether it's pointless or not. That's my thing.
Thank you. I think you drilled it down to two very important aspects. In terms of the benefits of doing research, in terms of the importance of doing research, I'd like to ask my colleague, Dr. Ray, you're somebody I look up to, because not only are you somebody who's had a very strong academic background, but I think I find you to be a continuous learner, given the fact that you have recently enrolled yourself into a training program. Now, what are the benefits that you think that a student really gets? Because if we want to make things more relevant, we must understand what is the benefit of that research. So if you could very briefly tell us what you think is the benefit for the student, because there are a few students in this audience. Yeah.
Of course. There are certainly benefits. The most important thing is by doing a research, and perhaps for many of you, this is going to be a first structured research enrollment in your life. So you will come to know how to do a thing methodically, following a fixed format, structurally correct way, step by step, and try to reach a conclusion. So it's more important to learn at this stage how to do it, rather than what conclusion you are bringing out of this particular research. So as a teacher, as a senior faculty, when you are reviewing research work of a student, be it an MD student, be it a DNB student, are we really looking into the conclusion and seeing that what disruptive conclusion he has made, which is going to change the practice? Perhaps no. It is more important to see whether he has done it in the right manner, which will help him to do such things in a better way, on a broader field, in different perspective in future. That is the most important part at this stage.
Thank you. I think, I think we would all agree with you on that. But I'd like to pose the question a little differently to my two colleagues over here who have, trained outside India. Now, in Western training, I doubt whether a thesis is an integral component of a training program all the time. And if not, why is it that we demand that it is important here?
Quite the opposite. To be a consultant in the UK, almost everyone will have done a dissertation. It is rare to be able to get a consultant job. It's not part of a degree program in the same way, but it is an expectation of the training years. So it goes without saying, everyone does it.
So what you're saying is that it is not a part of your degree, whereas here it is a part of your degree, but
true,
a
but
consultant position is dependent on
Yes,
doing.
but that's because the whole structure is different. People don't do a degree in quite the same way there. But it is an absolute requirement of coming out with your end of training certificate and going on to be a consultant.
Right. So in that respect, what the training programs in the West are often more than 3 years. They span a longer duration. They give you more background. What is it that you feel is in order to make research more relevant? What is it that you think is having seen both systems, that you can change or you can improve in order to make the research program or the thesis or research here better?
So being a doctor, there are two roles that we undertake. One is that I've got a patient in front of me. Between me and the death, between patient and the death is me. That's where we come in, and we are trying to save the patient, and that's for that you need knowledge and technical, clinical skills. The other role that we have is that, yes, there will be failure. And the moment we start asking the question to ourselves, why did I fail? The research component comes in, because there are gaps in knowledge, there are gaps in our understanding, and only way to improve the way we are looking after our patients is not for our benefits, also for the benefit of the patients, that we contribute to knowledge. And to make a contribution to knowledge is not that, like level 5 evidence, I am the expert, I know everything, I can smell a disease. That is not science is. Science is that there is a methodical approach to a problem. You do your research based on that, and whatever you conclude, then you conglomerate with other research in the same way, and then you come to the conclusion. That's how the guidelines come up. So whenever we are, as teacher, we are teaching our students for their thesis, the first objective I tell them is that you first thing you are learning is how to do a research. The methodical approach, that you are identifying a gap in the knowledge, and to address that gap in the knowledge, you are following certain methodology. Whatever methodology you adopt, of course, ethically approved, statistically correct, scientifically correct. And that's how. So the difference we found between the Western education system and the system over here is that thesis is part of the degree that we give here. So you can pass your membership examination within 3-4 years of training. But as Rosina said, that you have, if you want to become a consultant, maybe 1 or 2 years you have to take time off your clinical work, be in a laboratory, be in a research setting, you do your dissertation, thesis, whatever research you do, have a few publications, and then only you are qualified to become a consultant.
But
So
do you believe, for example, that the time that is available here to do research is insufficient compared to what you had in the West, for example?
It depends on specialty to specialty. Our specialty, my students are very pressed for time because there's a lot of clinical work. I wish there were more time for them. Within the department, of course, we try and allow them the time to complete their thesis, but that's not practical everywhere. So yes, I mean, I would prefer if there were dedicated at least a year set aside.
Set aside, yeah.
For undertaking appropriate research and taking the work forward. Yeah.
Thank you. I'd like to go to Obimonno now. Obimonno is one of the younger but extremely hardworking faculty that we have here. You know, sometimes I wonder that, you know, when we are talking about research in the context of DNB, for example, you are dealing, as Madam said, that you are dealing with, you know, DNB is done in a lot of institutions where teaching is not one of the job descriptions of the faculty member, right? And the faculty member is often very, very enmeshed and busy in clinical work. Do you believe, and this is again something that I want you to tell us honestly, that, you know, that do you believe that most faculty members in your, you know, your friends, your colleagues, do you believe that they have the training to train people in research?
So, in order to answer this question, I must give my experience because I did a DNB surgical gastro. It's been almost more than 5 years now. So when I did MBBS, so-called a premier institute, I never had a clue that there is something called research. When I did my MS, again another premier institute, somebody told me, "वो तो 5 साल पहले एक thesis हुआ था, you can do it." The first time in my life when I entered surgical gastroenterology training, the first day my guide told me, "What is your topic?" So there was a paradigm shift in the thinking. And then ultimately I did a randomized control trial in my training. So that was the first time when I was quite old to say that I actually came across what is a proper methodology, how to frame a research question, how to structure it, how to report, and what are the other aspects of a research. So that comes very late in our lives when we are in India and in training in India. And my relatives in UK who had done their MBBS training in UK, those small bit of concepts are ingrained into their daily lives from the very foundational years. So that was never there for me. So suddenly when I start writing a thesis, I understand there are so many deficiencies in me that it has never been addressed. So now, of course, another point is that the relevance of research. Now, a student who is coming suddenly in GI surgery or any other field, that person is absolutely new. So that person to understand what is a relevant research question is extremely difficult. So we have to do a bit of hand-holding because we have spent quite a significant number of years now into this field. So we can point out, okay, this is relevant. After so many years, I know minuscule amount of what is relevant in my surgical field. Of course, research methodology is something they can go through, learn, and then it will be easier for them. So the purpose of research in DNB, first thing I feel is that they should understand what is the research question, how the methodology is, and how you're going to work on it. And of course, your guide should be there to bring out what is relevance in your research.
Can I add? Okay. One of the things that we practically find challenging is the students will come to a new specialty, to a new place, and 3 months of time and 6 months of time is where you have to send the protocol. So and they're coming with the whole, like, we know that our Indian system is not a space of creative thinking, and it is more of memory. Having said that, I used to be very critical about Indian thing of memory based, but I now understand there's a lot of benefits for that, like in maths and multiple things we're doing extremely well, and there is a cognitive importance for that also. But having said that, when suddenly the students are there with, they are not confused about the speciality, they're confused about the space, they have to adjust to a space where they were not there, they're from different state and things like that, and then we are trying to make them understand this is research question, this is research methodology, this is, you have to go to IRB, and there is a deadline. It's a little bit overwhelming to the students also. And for the faculty also, when you have like clinical thing with responsibilities, and many private hospitals, if it's not, again, there's a pressure, revenue pressure is there. So we have to acknowledge that, right? So because, you know, there's no massive corpus to set. So in all these ecosystem, when they're put, there are challenges. Having said that, looking at all those things, I think there's so much that we can do, and so much we have done also. That's what I feel.
Yeah, so now that we've set some kind of a foundation to the issue over here, I mean, coming to the question of making things more relevant. Now, I think that we also need to define what is relevant, in the sense that, is it necessarily, does it necessarily have to be, if the goal is to teach people how to do critical thinking, if the goal is to teach people how to, you know, take a process step by step and reach a conclusion, no matter what the conclusion may be, then is our you know, the conditions that are set for MD DNB thesis in terms of research, are they too restrictive? Because is, for example, if you want to do research without the encumbrances of, you know, time, you know, training of supervisors, in terms of funds available to the hospital, do you believe that there is flexibility in terms of how to frame how to do research? In the sense, you know, option one, for example, for example, a very systematically done review of literature also, does it count as research? What do you think? That, you know, you learn how to critically read, you learn how to summarize it, you learn how to take the steps of a review process, and you publish it. It does not involve ethics, it does not involve, you know, many of the hurdles we face, the time hurdles in terms of submitting a thesis, writing it, presenting it to the IRB, getting a GCP certification for the entire team, etc. By the time a student finishes that process, it is nearly a year down the line. And then they have restricted time. So sometimes the time available to complete the research is also a challenge. So do you believe that there are alternative pathways where methodology can be learnt, but it doesn't have to be done on patients, or doesn't need to have a patient-focused topic? It could be, you know, how education is done. It could be a review on a topic. It could be something else. What do you feel about it?
I think for young people coming into a medical career, they have to understand why there are ways that we treat a patient. It's all come from research. They have to learn to ask the question. Nothing is set in stone. What we're doing today is not the same as was done 10 years ago, or will be done for any disease process. But how does that happen if we don't actually encourage them to ask a question and to think about, you know, what was said about the deficiencies? If we don't encourage them to do that at this point in their career, then when will they do it? They shouldn't think that everything they read in the textbook is set in stone and that's it. They're going to live with that for the rest of their career. That's not how it works. So yes, there are challenges, but I think, you know, having a clinical question, they're going to be doctors after all. Having a clinical question that they try to answer is actually very relevant to them for their future.
So what are the, you know, would you propose any changes or any modifications?
You said that this whole process takes them a year, but actually perhaps the thesis could actually move a few months back, because literally when they join a new institution or they've come to a new department, the first thing they're being asked is, what is your question? So to move it a few months back, because they even if that means they have a smaller number of patients, they would still learn the same thing, but they would perhaps learn the subject, whatever they're doing their DNB in. If the thesis moved into the second year rather than being the challenge of the first year, that might actually help them.
What do the panelists feel, for example, about the necessity of doing prospective research in some form versus the ability to do prospective versus retrospective research? Because there are two schools of thought. One is that by doing prospective research, you are learning how to consent patients, how to look at the ethical aspects of research, how to actually take a patient through the journey of an intervention, for example, and then summarizing your results. The counter view is that by doing that, you're necessarily only going to be able to do this in a very small number of patients. Most centers are relatively small, and therefore you are always going to have underpowered studies. You're going to have observational studies. Who is going to take care of the adverse effects of intervention? Where is the funding for that? So there are a lot of logistic, financial, statistical issues there. So your thoughts on that?
Exactly. Are you going to take that question, or can I add some things? So I think, Indranil, now let us remain confined on this particular topic that we are discussing, thesis of DNB students, not a research or thesis work in general. Now, relevance, relevance is always related to that perspective, one particular context, a perspective. So for them, a research is very relevant because they will have to submit a thesis within a stipulated period. Otherwise, they will not be allowed to write the exam. So they know this is very relevant for me. I shall have to submit the thesis. And they are having time constraints. They will have to clear the internal exams, they will have to read, they will have to learn, and they will have to prepare for the exams. So time constraint is always there. And now, if we feel, I seriously feel and I sincerely feel that things can be changed, and it is more important to learn from a senior or from a teacher a few basic points regarding statistics, basic things of computer methodology, how to use and involve different tools and associated things, and doing a structural research when we are going to do a scientific work. And probably this is going to be the last opportunity. 3 years down the line, they will not get a second chance to ask these questions to others. But those things in this particular context will be less relevant for them because they will have to write the thesis. They will have to complete that thesis. So it is going to be more relevant for them. So what I think, we should be more flexible. And the example which you are giving, that whether it is more important to do a prospective study or a retrospective study. We know when we are selecting a thesis for a DNB student, and I underline that, we are giving them the topic. A fresher joining the DNB program after MBBS, they don't know about the subject itself, how he or she can decide a postgraduate thesis topic. When a topic is being assigned, they have little idea regarding that. Probably 1 year down the line, when they are deep into it, they may think this is not that relevant. I would have been happier to do something else. So whether it is prospective or retrospective, they can do anything. But they must know while doing it, they must be taught, they must be shown, holding their hands, that these are the pluses and minuses, these are the merits and demerits, pros and cons of doing a particular study, prospective, retrospective, ambispective, and when you will plan something in future, you must take these things into consideration. So those flexibilities must be there.
If I can add a little bit to that. I'll give an example. See, the research topic is something, and the set goals that my student will have a publication or a thesis submission in their deadline. So what we try to do in our department, it's almost always an observational studies to start with. I'll give you my student's example. Now she will be working on tumor infiltrating lymphocytes. This topic she has been given is just to look at the numbers, okay? And the moment she starts to read about it, she asks me the question, should I look at CD8? Should I look at CD4? So this is what I want. That they are coming up, when they're reading about the topic they've been given, they are coming up with their own ideas, because the innovative brains will always do this, and that becomes a lifelong study. So the research topic remains relevant throughout the life. I mean, there are people who have been working on one simple topic throughout their life, even when they become professors. But the deadline now is that this is an observation, because within that time frame, very difficult to do any prospective randomized control trial or anything, unless it's something we have got a difference of 0.5 and 50. Otherwise, you can't do that. So observational exploratory studies, we do within that time period, do your sample size calculation and make it relevant. But the question remains, and you can continue working on it throughout your life.
Yeah,
So
thank you. I'll come to the last part of this panel discussion. We are short of time now. Is about research being translational. And, this is an important topic because, we know that research is not unidimensional anymore. It is always multidisciplinary. And not just multidisciplinary across clinical specialties, but there's a lot of, basic science, etc., that goes on into it. Honestly, do you believe that translational research in a DNB thesis is how many of you think that it is easily possible? Or do you mostly believe that it is a little challenging because of the, the infrastructure, etc. requirement?
If the student comes up with certain things, like being in Bangalore, there are times they come with AI or somebody they know saying that is they come up with things. But again, we caution them because this is their first research. So even with Dr. Abhijat said last time when we asked, like, what is when you put thesis, what was in your, he says, don't give them RCT. Why? Because, if you are first research, because in an RCT, it's an experiment you are design. When you're doing a design of an experiment, the responsibility of whether there is a equipoise and something happens, who takes it is the researcher. So it's not a mature researcher to start with RCT. So go with basics, basically to understand what is methodology. Now, if they've already done many things and there is a translation they come with, then we will, based on the maturity, we will give. Otherwise, my thing is like, translation in sense, if it is towards how it is a feedback or something like that, but not in terms of basic science, clinical, and in terms of suddenly translating into it.
Obimanyu, I wanted to ask you that, suppose you had a translational question. Do you believe that an MD or DNB thesis is maybe an opportunity to introduce the student to the translational topic? But what are the very quickly, what are the hurdles that you think that are there from your perspective, and how can one cross those hurdles in terms of funding or in terms of whatever you think may be appropriate?
See, one of the very big problems of translational research is resource constraint. Very big resource constraint, the economics of it, what is the hospital infrastructure, how you're going to, coordinate with the lab people and how we are going to do that. So that is very difficult, but I don't think it's not undoable, doable because like a hospital like us, which does significant amount of facilities, the student may not actually publish all the results. It may be start of a very long translational process. Huh? It may be a 10 years research, but the student may just, open the discussion with the preliminary results of it. So it is possible. But you have to be realistic about the hospital setting. You cannot just do something and then you don't have the infrastructure and the facilities to back with it. So of course, you have to be realistic with whatever you have.
And final question to everybody. Doing better research, doing translational research, what is the importance of funding being available for it?
And that's crucial. Translational cannot happen without funding. But from a student's point of view, I think translational only works if there is a department that has an ongoing program and the student plugs into a small section of it. It can't start de novo with when a student or within the time frame that one individual student has.
Exactly. So, I mean, those departments who will have their own research funding, that can be added on. Some more funding can be applied for, but we always have a little bit of leftover from our previous funding, and those are the ones we can use just to add on to the. But I believe clinical for clinicians. I mean, if it's a laboratory subject, of course, it's for laboratories. For us as clinicians, we prefer a clinical subject, an observational study to start with, and if we can add on some translational research where the funding is available from your departmental.
That will open the horizons for the business. Thank you very much, I think. Yes. Yes.
Because having spent my time in this, regarding the thesis or whatever research or thesis in the DNBs, and then the moment the student enters, his only idea, his goal is to see that he gets a degree. When you do some sort of thing which is going to be excellent one also, he will be forgetting, he will not be continuing to do that. So main intention is to see how he settles in the life. That's how. So what I feel is, definitely research has got a place in this, and it has to be developed. Why can't we separate? So first we give them degree, let them decide whether they want to be on this side or this side, and provide avenues to the research. Government has to take it. I mean, this may not be palatable if I speak like that, because the topic, the moment the student is given a topic, the teacher, the guide also doesn't know. So he also doesn't know what is he doing. Honestly speaking, with due apologies to all the people, including myself also. So they somehow complete the topic and all that. And then he passes. If they are not given sufficient time, they will be asked to do it, rewrite and all that. There ends the matter. So this is not going to serve the purpose of our country to research matter. It should be different because it involves money. It involves so many things. Poor fellow, how can he spend it from pocket? Neither the industry is going to support nor that. It's only your eyewash. That's what we are doing. Having spent 40 years in medical colleges and all that, today I am able to speak loudly because there is nobody to punish me. Yes. That is one.
Thank you.
Second thing is and regarding research also, everything is research. You ask for yourself, why, what, how, you get answer. You will do it. One simple example I'll tell you. When I was an intern, house surgeon, the intern house surgeon was supposed to do everything, including giving drips, doing tests and all that. So one day I got vexed. One severely diseased fellow, I have to give daily IV fluids, blood draws. One day I got vexed. I put a needle, put some heparin in that, kept it like that. So that daily how to get the vein. So my professor came and banged me. Useless fellow, what is that you are doing? You make air embolization. True, but I got it. Now the same thing has evolved as intracath. If there was somebody, godfather for me, I would have become a millionaire by this time. Because
sir, 1 minute is over, sir. 1 minute is over, sir.
Yeah. Thank you. I'm sorry, but this regarding the students, I'm telling you. You ask, there is everything research is here. My professor used to say that Western, ESR study we used to do. Why this tube should be Western grain?
Thank you, sir.
method.
Thank you.
It
Thank
should
you,
be-
sir.
it cannot be
We have time restriction, please.
Sorry,
Please.
forgive me. Thank you. These are the inputs I take you.
Thank you
to
very
the
much.
panelists.
Wonderful
Thank you.
discussion. Very, very clarity. Very, very wonderful discussion. Please stay back. So now I request Dr.
Can I
Biswas.
add something? 1 point?
1 minute, sir. 1
yeah,
minute.
Yeah, on less than a minute. So I think in US, they have MD, PhD, another pathway. You start from the MD, you go into a MD, PhD pathway, and then you select your research and then publish and then go into teaching faculty. This is a different degree. I think in India, Indian Institute of Science, they are developing that pathway. So this is one. The other point what I want to emphasize is, depending upon the institution and the faculty and the students, it may select out. Actually, it's not everything is going into S. Some people will be selected out. Those candidates who are interested, they pick up and may become a faculty sometime.
Thank you, sir. Dr. Rahul, next time we have to give 1 hour for this topic. A wonderful topic, very interesting to everybody. Now I request Babutosh Biswas to honor our panel members. Please honor Dr. Indranil Malik for conducting wonderful program, moderating very well. Now please honor Dr. Joydeep Bhaumik. Senior, okay, sir, okay, please give everybody. Thank you, sir. Thank you very much. Now we coming to the second next session. This is very important session. Practicing evidence-based medicine is the present trend and essential also, because a lot of people, they are coming with AI, Google and all those patient anchoring. They are coming with the knowledge of AI and Google. They are asking everything to us. They are asking what is how you diagnose, how you treat, what is the thing. So evidence-based medicine is the most important thing now. Now I request Dr. Pratik Jain, Senior Faculty, Head and Neck Oncology, Consultant Department Surgical Oncology, Tata Medical Center. Please come and talk about evidence-based medicine in relation to the oncology. Please, sir.
Very good afternoon to everyone. I would like to first of all thank ANBAI and the organizers, Sushri and Rahul sir, for giving me this opportunity to speak in front of such an elite group of people from across the country. We've in last 1 hour we have seen how research goes and what is to be done when we are doing research, how to publish it and all those things. But if from a student's point of view, the main question is, what should I do if a patient comes to me and asks me a question? I mean, am I supposed to tell him that, no, this is the research that is to be done and that then I will give you this, or I have done this research and that research? No, that is where in clinical practice, what you have to follow is what is called evidence-based medicine. And I understand we are into our lunch break now. The minds are getting hypoglycemic, so I would try to be brief and crisp in my presentation as early as I'll try to finish as early as possible. So in next 20 minutes or so, what we are going to do is we will look into the foundational principles of EBM, impact of EBM on modern clinical practice, what are the other forms of practice which we have heard of in our clinics, and then how are we going to incorporate EBM in oncology. So what do you mean by EBM? EBM is basically a cornerstone of modern healthcare, right? It provides a systematic approach to improve patient outcomes and reduce uncertainty in medical practice. What do you mean by uncertainty in medical practice? If a patient comes to me or a patient goes to anybody across India, the evidence remains the same and the treatment that he will be offered will be same across India. That is evidence-based medicine. And what does it lie on? It lies on these three pillars. Conscientious use of medicine, of the evidence. We need to make sure that best available scientific evidence that we have is to be put into practice. It should be transparent and clear reasoning should be there behind every clinical decision that you take. And it should always be in combination with the patient. Patient should always have a say in what treatment is he going to get, right? So core principles, you have to understand this hierarchy. If you're looking at evidences, systematic review of RCTs, it forms the highest level of evidence, followed by individual RCTs, all or none studies, systematic reviews, and so on. This you don't need to take a picture of this. This is available on internet everywhere, right? So, but how to go about EBM? Whenever I talk about evidence-based medicine, there is always a 5-step approach that you should look at. First is you need to ask or formulate a question. What is that I am what is it that I want to ask in form of a PICO? PICO is basically patient, intervention, comparison, and outcome, right? So that you can create a question which can be answered in a logical way. Once you have the question, you have various platforms across which you can ask this question, like you have PubMed, you have Google, you have Research Scholar, you have everything due to the information technology available to us. We can definitely get into this, the information about this quite easily at our fingertips. So we need to look at the best available evidence through comprehensive research through databases like Medline, Embase, Cochrane libraries. PubMed will give you a lot of research articles, and you have to follow the recent articles according to the hierarchy that we have seen, right? And then you have to critically evaluate which article is relevant to your question, because there is a plethora of articles on every subject. Every day there are thousands of articles that are being published, right? So if you are having so much to wade through, you have to find out which article actually summarizes the question that you are asking and gives you the best available evidence for that. Then you have to integrate that knowledge that you have acquired into the patient care and follow that. It doesn't end there. Once you have implemented it, you have to look at whether it affected your outcomes or not. That is where you understand from question to decision how evidence-based medicine works, right? So if you look at this is a very famous example. Now, if you look at currently using aspirin in a cardiac patient is a norm, right? Whenever a patient comes, you immediately, if he's having a symptom of cardiac arrest, you would give immediately something which will stabilize his. But this was published in 1988, but a study done in 1997 just identified that only 45% of patients received aspirin. So even after 10 years, there was a big bridge to be traversed from the research that was published till you have a clinical application of the same, right? So that is where EBM or the evidence-based medicine comes into picture. So this example just tells us that translating robust research should be transformed into a consistent and timely bedside intervention. Unless and until it happens, you will not have any use of doing research. But what are the challenges in EBM when we are practicing EBM? First is information overload. We are actually living in a generation of information and technology boom, right? As I said, thousands of articles are coming up every day. And it is very difficult for somebody to go through all the literature and to be apprised with what is latest. There are time constraints. I mean, we heard experts say there's no time to do research. How are you going to ask and go sit on a computer and find out all the research that has been done on the particular topic? And there are training gaps. Like we don't have clinicians who are trained. Again, another point that was raised in the panel before this, right? Many clinicians, they don't know how to do research and all. Now, it is very important that we navigate through these barriers so that evidence-based medicine becomes crucial. That is why it is very important that we should have a continuous learning attitude. The decision making should be shared between the patient and the clinician, and we should always have technological integration. But this is about evidence-based medicine. There are other forms of medicines that are being practiced. Any Amitabh Bachchan fans in the audience? Can I have a show of hands? Yeah? Everybody is aware of this dialogue. Yeah? मुझे जो सही लगता है मैं वही करता हूँ. This was a very famous dialogue from Sarkar. This is called eminence-based medicine, right? So then there's another dialogue from Amitabh Bachchan only. कोई भी नया लक्ष्य मनुष्य की साहस से बड़ा नहीं, हारा वही जो लड़ा नहीं. This is confidence-based. A surgeon can say that I can operate anything. Unless the tumor is attached to the operating table, I will operate that patient, right? So this is called confidence-based medicine. So there was a very good article that was published in BMJ in 1999, which told us that evidence-based medicine is important, but it gave us various other forms of medicines like eminence-based medicine. The grayer the hair, better is the opinion, right? Then there is Vehemence, the one who can shout the loudest, his opinion will be considered as the best, right? Then there is eloquence-based or elegance-based. If my English is proper, yes, my opinion has to be thought of as the best one. Then there is providence. Once I can't do anything, so let me pray to God that everything will happen to the best of you. Diffidence-based. Now nothing can be done. Let us see. We will not do anything. Let's just watch and see how things happen. Then there is nervousness. This is a newer one. I mean, where you are worried about the litigation, so you just try to cover all your bases and ultimately do nothing or do something which is over the board. And last one was the confidence-based that I just explained. So these are other types of practices that we do see in our day-to-day life. But I'm putting this slide up only to condemn that these are not the ones that we need to look at. Only the first one in this list, evidence-based, where the evidence is a randomized controlled trial or a meta-analysis, and you need to look at the odds ratio or the hazard ratio or whatever relevant ratios are there to bring that particular evidence into your practice. Now, the second part of my talk was about how can we put this into oncology practice, right? So if you look at the treatment selection, EBM, it does help the oncologist to choose the most appropriate treatment for that particular patient, right? It has to look at all the clinical trials that are there, all the studies that demonstrate a therapy's effectiveness before implementing that therapy. It also provides a framework for integrating research evidence into decision making. I have some other type of experiences. The research is saying something else. we can, and also the patient will also have his own preferences. So all that thing comes into picture when we decide on any particular treatment for a particular patient. Once the treatment is done, it also, and EBM also encourages us to look at our outcomes and evaluate our outcomes. Just doing surgery for a particular patient is not enough. You have to look at the collective effect of your treatment and then ultimately decide whether you need to change your practice or not. And then once you have found out what is happening in your audits and all, you can make changes to your practice so that your quality of treatment or the patient care improves. Right? Now, benefits, it's the same. Once you practice EBM, you will have improved patient outcome because you're standing on the shoulders of the giants that have already done some study in their lives, right? You have their effectiveness and safety data to decide what treatment is going to be given to your patient. You can tailor your treatment as per the patient. There would be a personalized patient care that can be given. It also helps in medical care to be advanced, right? Your experience, once you publish it, becomes something that the other person can take help from. And it can also help the authorities to find out guidelines, to make guidelines which, if, I mean, as I said, it is not possible for everybody to go through all the literature, but then there would be some select task groups which can understand the evidence that is available at that particular point and give some guidelines so that everybody can follow those. But now this is about students. So I just wanted to highlight what are the issues that are faced by students, right? There is information flood. There is no doubt in that. Lack of time. Students, I mean, if the consultants are saying they don't have time to read and research, think about student who is on ground working on everything. And then again, and then the third and most important thing is, even if I have a particular study which has come recently, we don't have a full text available for that, right? So as this is a gathering, we just heard in the morning that everybody was going to discuss tomorrow on what are the further steps that you need to take. From this EBM point of view, I had a suggestion, like NCG, can we ask ANBAI or NBE to provide access to some important journals? NCG does give some journal access to all the institutions who are part of it. If NBE or ANBAI can also facilitate that, it will be a very big step in students understanding different process, right? So to conclude, what I would say is EBM, it bridges the science and humanity, right? And it makes sure that the care is effective, safe, and it is tailored to each individual. Thank you for your patient listening. If you have any questions, I'd be happy to take those.
Hi, thank you. That was a wonderful talk on evidence-based medicine, and the 7 alternatives to EBM is something which I have in my slides as well every time I talk to medical students. I think in a way it links to the previous panel discussion as well. Just a couple of points to make. First thing is, research is absolutely relevant, and there is no doubt about it. Without research, science will not progress. But is Indian milieu ready for it? Even in the West, I had the opportunity to work for about 24 years, of which 14 years I was a consultant in the UK. Research is not for everybody, and that we need to be very honest in accepting it. And so there need to be a separate kind of a cohort of people we need to identify who are likely to progress in research, and we need to support them. That is a realistic way in which the resources available for research would be best used, actually. So practically, you made a very good point where if you haven't learned to apply research for patients of today, there's no point in doing research. So I would say the dire need of the time is, number one, we need to teach evidence-based practice for every trainee, whether it is through NMC or through National Board. I think they need to learn to interpret available research. If they all can do, 2 things will happen. One is they will identify gaps in research, And then we can tell our trainees, go and do research. This is a very well-designed study done in Scandinavia and Nigeria. Now use that design, but it is not relevant for Indian patients. Now you go and design a research study and do it in Indian patients. That is the way we can promote Indian research, actually. In terms of, so I think that evidence-based medicine has to be for everybody. And as an introduction to research, having a thesis for both MD and DNB is critical, because that need to start them in the journey. One of my trainees came up with a very good idea, a practical solution. My second year, third year trainee said, only now I understand what topic would be best done in this institution, based on the number of cases available and the kind of clinical material. So I think, as Doctor was mentioning, rather than pushing it to second year, ask the second year students what would be the good research topic for the department, and have a collection of them, initiate them, get them only into the process, let them understand the process. That is what is practically doable. They all should have introduction, but they must be conversant with principles of evidence-based practice. And research can, real research with creativity as to compete with the West, can come later, nurtured by prominent, committed institutions like TMC. Thank you.
Thank you so much for the presentation. Two comments. One, following up with Dr. Ganesh regarding the critical necessity of learning evidence-based medicine. National Board has already put it into process. They encourage every department to have regular journal clubs. And the journal clubs are supposed to have a bouquet of current articles where the faculty is to guide the students into understanding what was the research, what was the methodology, and whether the conclusion was really scientific or not. Unfortunately, since I had a huge academic program in the Narayana group, I find that because the faculty are themselves not very interested in following up on journals, reading journals regularly, they take the theoretical classes on various topics, but when it comes to the last section of the journal club, I usually find that place to be, they have not taken it. So process is there. We also need to make ourselves better in this thing. Now, the other one you raised was a very valid question, and I want to tell all of you that ANBAI has been talking to the National Board for the last 12, 13 years to have a national journal subscription. From the moment I have joined ANBAI, I have seen seniors like Dr. Chabra, Dr. Lingaya.
Even with government also.
Yes, they have repeatedly asked the board and the NMC to make high quality peer-reviewed journals available. They have always said that they are in the process, and tomorrow I will again raise the issue in the interactive session. This January, the union government rolled out a particular program called One Nation, One Subscription, ONOS. And we congratulated the PMO for this initiative. The One Nation, One Subscription is initially supposed to be rolled out for the central government public institutes and later to the private hospitals. But unfortunately, after that notification, I don't really think much has happened in that. So we need to follow it up, but thank you for your kind suggestion.
Thank you, sir. I think we have to appreciate scientific session people. Sir, wait, please. Scientific session people, at the before lunch, they have put Dr. Pratik sir's talk. Hypoglycemic audience, he made into dynamic audience, and good interaction went on. Thank you, sir, for a wonderful presentation. Now I request Dr. Deepak Sanjay. Dr. Deepak Kumar. Not there. Okay. Now I request Dr. Rahul, please give memento to Dr. Pratik. Welcome, sir. Dr. Girdhar Gyani, sir, welcome. Thank you. We are lagging behind half an hour, so now we will break for the lunch. But my request is we will complete the lunch within half an hour and come back at 2 o'clock for the second session. Thank you.